Sir, I requested our State Vice President West Zone, Dr. CP, yes, sir, to give his address.
Good evening, one and all. Today is having a very important and hard topic that too in South India. It's a bird flu. The speakers are very good and they are very talented and very well experienced people. They will enlighten our doubts and uh, all the important points and valid points for us to clarify our mind regarding the bird flu.
Is my slides visible?
Yes, visible and order.
Yes, sir. Thank you very much. Respected President, respected Secretary Parameshwaran sir, and respected CGP members, Dr. Karthikeyan, and the team of CGP members and senior IMA members of Coimbatore and Tamil Nadu. So with due respects, friends, today I'm going to talk to you about a very, very important hot topic that's called bird flu. Friends, you will all agree with me. This bird flu is primarily a zoonotic disease that affects mainly poultry and aquatic birds. There can be an occasional spillover to man and also swine. Swine is otherwise pig. So usually from the birds, it goes to pig and then comes to man, or can come directly to man. So last 2009, we had a lady in Mexico by name Mary. She was having ducks. She was also having pigs in her farm. From the duck, the bird flu entered into pig, and then from the pig, it came to her. That was called a swine flu. She died within a couple of days. And within a month, within 30 days, this swine flu spread across the globe. So similarly, we have a first case of bird flu was noted in wild geese in China in 1996. Then later, 1 year later, the first human case was identified in Hong Kong in a boy who was playing, was playing in his house with the chicken. So from 1996 onwards, it started spreading. Now, as per WHO records, more than 261 cases have been reported globally, human cases. The present strain that in Chennai, isolated from the crows, is H5N1. Friends, this is a candidate pandemic vaccine, though the WHO does not say pandemic vaccine, because the pandemic potential is there, but pandemicity is low. I'll tell you why. So please remember this, whenever you have a very sensitive animal disease like this, usually it is confirmed by ICAR Nishad lab in Bhopal. Here this H5N1 was confirmed in Bhopal. Usually by birds I mean crows, herons, egrets, pelicans, all those who fly from one place to another, migratory birds. They carry the remnants of dead birds and drop them in the poultries and the lakes and sanctuaries, thus causing the spread of the virus from one place to another, from one country to another. So, though it is identified in Chennai, it may not be confined to Chennai alone. So, friends, I request all of us, not only doctors, the entire government and the public, we have to be very, very cautious regarding this, the incidence of H1N in crows in Chennai. Even the droppings of the infected birds are contagious. So sometimes when you're traveling in an infected place, avoid going in a barefoot. Even in your rooftop, if you're walking in the morning, always wear shoe or chappals and then walk, particularly in and around Chennai. So having seen this, the current scenario is the H5N1 was earlier detected in Kerala and Bihar, now in Tamil Nadu, recently in Andhra. The crow is basically a sentinel bird. You must actually thank the crow because it is something that gives an alarm bell. It gives an ecological warning to us that something is happening, something is going to spread. So basically, by the word sentinel means it is a watchman, watchbird. For example, I am a WHO sentinel doctor. What I do is I collect samples of children who come with ILI, influenza-like illness. We send it to CDC and to WHO for knowing what strain of virus is prevailing in the country. So similarly, in nearly around 168 countries, many doctors like me are there for WHO as sentinel doctors. So crow acts as a sentinel bird. So we have to thank the crow. In fact, one of the this H5N1 is called highly pathogenic avian influenza. By that means the mortality when a human gets this H5N1 mortality is nearly 60%. Fortunately, there are no human cases as of now. And the most important message to all the doctors, hello? No, most important message is please mute yourself. Please mute yourself. I request everybody to mute yourself. No need to panic. Please remember, human-to-human transmission, particularly in H5N1, is extremely low. I'll tell you the reason why it is low. And the good thing is it does not spread like COVID or swine flu. Spreading of an illness epidemiologically is indicated by R0, that is reproductive index. For infections like chickenpox, measles, R0 is very high, more than 12. Whereas fortunately here in influenza, particularly bird flu, it's extremely low. We are happy because of that. That's the reason so far we haven't had a human case so far. So many a times when you have such an outbreak, all the doctors attend the meeting, whereas patients do not attend the meeting. So it is our duty. The patients will come and tell you that they have got fever. It is our duty to find out whether this fever is a viral fever or a bacterial fever. If it is viral, is it influenza-like illness? If it is influenza-like illness, whether it is ordinary seasonal influenza or a bird flu. So during this conference, we are going to tell you crystal clear message how to identify whether this is a suspected case of bird flu sitting inside a 10x10 consultation room without doing a big lab test, how to arrive at an empirical diagnosis. The first thing is, whenever a patient comes to you with fever, particularly a child, you must know whether it is bacterial or viral. There are simple 5-point rule to arrive at a diagnosis by using what you have studied in your undergraduate curriculum. When a child gets a sudden onset of high-grade fever in a previously healthy, playful child, it swings the pendulum towards an organism that has got ultra-short incubation period. I'm sure you will all agree with me. Viruses have got ultra-short incubation period, whereas bacteria, the incubation period is days and weeks. So whenever there is a sudden onset in a previously healthy child high-grade fever, it is, until proven otherwise, it is viral. At the same time, if more than one member in the family is having fever at the same time, if you ask the mother, what happened? She will tell that grandmother had yesterday, father had today morning, child has today evening. More than 1 or 2 members because of the ultra-short incubation period. Many members in the family, many members in the street, many members in the colony, many members in the city, many members in the state, many members in the country and the globe. Viruses have got propensity to cause pandemics and epidemics. So when there is dissemination in the family, it is probably virus. And when there are multiple sites that is involved, eye is red, throat is congested, nose is watery, probably dissemination is hallmark of virus, whereas bacteria localized to only one site. You can have a bacterial acute follicular tonsillitis. You can have a bacterial lymphadenitis. Only one site will be involved. When there is multiple system involvement, if you ask the mother, enna pannaduma, immediately mother will tell, என் பையனுக்கு இருமல் இருக்குது, காய்ச்சல் இருக்குது, வாந்தி பண்றான், வயிற்றால போகுது, உடம்புலாம் பொடிப்பொடியா இருக்குது, மூட்டு வலிக்குது, கண்ணெல்லாம் பூளை கட்டிக்குது, தண்ணியா ஒழுகுது, தும்மல் இருக்குது, போதும் ஸ்டாப் பண்ணுன்னு சொல்ற மாதிரி verbal diarrhea. If multiple systems are involved, probably the child has got viral illness. By multiple system, I mean in the respiratory system cough, in the GI watery diarrhea, in the skin rash, multiple systems. Dissemination is hallmark of virus. Localization, child will have a bacillary dysentery, only large gut involved, bacteria. Bacterial UTA, only one system is involved. You can have bacterial pneumonia, only lung is involved. So one system involved, probably bacterial, multi-system involved, probably viral. The last fifth point is how does the child behave during 2 fever episodes? That's called interfebrile period. When the child is up and about playing, it swings the pendulum towards virus. Whereas in bacteria, even though the fever comes down in enteric fever or pneumonia, grunting will be there, loss of appetite will be there, child will be dull, even if the fever has come down. So if the child remains normal, up and about playing during interfebrile period, it swings the pendulum viral. Having done this simple 5-point rule in every child who comes to your clinic for fever, you can make a reasonable diagnosis. This is a short pyrexia, nil localizing, probably viral. You monitor for danger signs, educate them, give them only paracetamol, no antibiotics, send them home. So these are all signs and symptoms of a viral fever, which you can do just without doing any lab tests, just applying your knowledge alone, sitting in your 10 by 10 chamber, arriving at a viral fever. Having arrived at viral fever, let's see some of the respiratory viruses. If this particular child has got a severe sore throat, sudden high-grade pyrexia, and a dry hacking cough with or without GE symptoms like nausea, vomiting, diarrhea, with or without myalgia, myositis. If these symptoms are there, these symptoms are called as ILI symptoms, influenza-like illness symptoms. So these are all caused by many viruses, including influenza virus, para-influenza virus, adenovirus, your rhinovirus, respiratory syncytial virus, human metapneumovirus, your human coronavirus. All these 7 viruses cause this ILI. So once you've made a diagnosis of viral fever, once you think it is an influenza-like illness, the next important thing what you need to know is, particularly during this season, you have to suspect whether this is a bird flu or not. So these are the 6 important, the most important slide in this meeting is this. You can take a picture, or at the end of the meeting, you can send a request to my WhatsApp number. I'll send you the slides. The first thing to suspect is you have to ask for a history of exposure. In the last 14 days, did you touch any sick bird, or did you lift any dead bird, or did you feed any sick bird? So if it is yes, you have to suspect. Then you have to ask for consumption of raw, undercooked poultry. Particularly some people, those who are going to gym, are known for taking raw eggs, or unboiled or semi-boiled egg, or undercooked food, that is in the sandwich or something like that, which is a meat or a chicken that is not cooked properly. Please remember, this virus is heat sensitive. In your normal cooking, in your day-to-day cooking, this virus dies. So next is occupation. What occupation do they have? Ask, if the patient comes to you with fever, with ILI symptoms, you have to ask them, are you working in poultry? Are you a veterinary person? Are you working in zoo? Are you a laboratory technician? All these things are very, very important. Sometimes the corporation worker who goes and cleans the dead crows and other things. If the corporation occupation is positive, then you have to have a high index of suspicion. Then another important question is there a human exposure? You have to ask them, is there a suspected or confirmed case of bird flu in the house? Sometimes if it is so, then you have to take it as an exposure positive. You have to treat it as a suspected bird flu. The 5th important question that you need to ask in every child who comes to you with fever is the travel history. Did they visit an outbreak area in the last 2 weeks? That's very, very important. Now the outbreak area is around Adayar, so Velachery, all those areas. Did they visit there? You have to ask them. If all these things are positive, you have to have a high index of suspicion. Suppose if these are negative or one is positive, then very, very important is to assess the rapidity of the illness. Whereas in a simple seasonal flu, the rapidity is very slow. Whereas in bird flu, rapidity is very high. child or an adult who comes to you with high-grade fever, dry cough, sore throat, and GE symptoms and myalgia, rapidly goes to breathlessness on the next day or within first 3 days. The patient develops dyspnea, child goes in for hypoxemia. There will be associated with chest pain, cyanosis. Many times they do have hemoptysis and altered sensorium. If these things are there, immediately you have to suspect bird flu. And then, because why you have to suspect bird flu is this mortality is very high, more than 60%. Primarily because of two complications. One is pulmonary complication, another is extrapulmonary. There are three important pulmonary complications. One is primarily this virus has got affinity for the lower respiratory epithelium, that is called tropism. They can have a rapidly progressive pneumonia. And the secondary bacterial pneumonias is very high, particularly in bird flu. And mixed pneumonias progressing to ARDS is very high. Whereas in extrapulmonary, most of these young children going for shock, young adolescents going for MODs, they going for renal failure rapidly, and also coagulopathy, myocarditis, encephalitis, very common in bird flu. Because of these 8 reasons, the morbidity and mortality is very high. You have to act fast. By acting fast, suspecting and acting fast, on one hand, you have to do a test, RT-PCR. Another hand, before you report, wait for the report, give Oseltamivir. By giving Oseltamivir in a suspected case of bird flu, you can reduce the mortality to practically to zero. So that's the importance of attending such CMEs. So if you look at the pathogenesis, this virus differs from your normal seasonal H1N1 virus by having the presence of PB1 RNA. What is this PB1 RNA? This is an RNA that helps facilitates the virus to multiply even at high temperatures. Normally, whenever an organism enters our body, our thermostat in the hypothalamus raises the body temperature, so that by increasing the body temperature, it reduces the viral load. In any viral illness like dengue or in flu or in any chikungunya, rising temperature is a protective mechanism. Unfortunately, in bird flu, the temperature goes up, the viral multiplication also goes up. That's an one important thing. And as I told you about tropism, many viruses have got tropism, liking for certain tissues in the body. This bird flu has got lower respiratory epithelium tropism, that immediately when they enter through the eye or the nose or the mouth, they immediately go to the lower respiratory epithelium. Cause starts destruction within hours. Primary viral pneumonia happens within hours. Secondary bacterial pneumonia to the tune of 25% happens within hours. If you look at the extrapulmonary manifestations of bird flu, many of these children, even with milder symptoms, along with the sore throat, dry hacking cough, body pain, they do complain of nausea, particularly upper abdominal pain, severe gastritis, diarrhea, myositis. And a clue for the general practitioners who sit here is that when you have a child with ILI or an adult with ILI, if they got a pink eye or a conjunctivitis, please think of two viruses. One is bird flu, another is conjunctivitis. Go back and take the history properly. Rapidly, they go in for multi-organ system dysfunction, and many of them develop present with epistaxis and encephalitis. The high mortality in young children, particularly children less than 5 years, is due to cytokine storm. And always remember, whenever you have a child or an adult with severe acute malnutrition or anemia or vitamin A and D deficiency, because of the reduced adaptive and mucosal immunity, the mortality is high. So you have to treat them aggressively. Even a mild case of suspected bird flu, you have to treat them with double the dose of Oseltamivir immediately, as early as possible, probably within 24 to 48 hours. So many a times in your OPD, you can have children or adults coming to you with a simple influenza-like illness with a suspected history. In those cases, always look for comorbidities. Is a person having a chronic disease of the brain or a heart or a lungs or liver or kidney? Or do they have immunosuppressive conditions like HIV or on steroids more than prednisolone 2 mg per kg for more than 2 weeks? or do they have disease like asthma, COPD, diabetes? The most important comorbidity that we notice in adolescent children is obesity. Particularly during COVID time, we had lots of children's obesity in our hospital, in our ICU, who were on ventilator for weeks together. Those children had a BMI more than 40. And of course, all viral illnesses, children below 2 years of age and adults above 65 years are vulnerable for a severe disease, even if the symptoms are mild. And please remember, pregnancy by itself, the mortality morbidity is very high, nearly 33% high. So please mute yourself. I request everyone to mute yourself. If these 11 conditions are there, these are all called important comorbid condition, not only for this virus, for any virus, for dengue or flu or any other virus. You have to be very, very cautious because the mortality morbidity is high. In such a situation, you need to, on one hand, you have to take RT-PCR, nasal or throat swab. For children less than 6 months of age, take a nasal swab. For older children and adults, you have to take a throat swab. That is reverse transcriptase polymerase chain reaction. In accredited labs, it has to be done for H5N1. As soon as you take on one hand, other hand, you give Oseltamivir. Particularly for this virus, as I told you, it has got a rapid progression. Mortality morbidity is very high. You need to give double the dose of Oseltamivir. Generally, in adults, we give 75 milligram BD for 5 days, whereas in bird flu, you need to give 150 milligram BD for a period of 10 days. Please remember, if the symptoms are mild and they don't have comorbid conditions, you can manage them at home with home isolation. And another important thing is, as I told you, the incidence of secondary bacterial infection is very high, particularly in bird flu, particularly when they got comorbid conditions, immunosuppressed conditions. You need to start on broad spectrum oral antibiotics, even in category B, even when you are treating them at home. The same child, if you have a mild illness, if you think it is seasonal flu, if they don't have any history suspective of bird flu, in such conditions in category B, based on your judgment, you can give Oseltamivir and do not start antibiotics. For bird flu, 3 important things: early Oseltamivir, double the dose, double the duration, do lab tests when they have comorbidity, and also start on antibiotics early. This is an important slide. Whenever you see a patient, a child or an adult, if they got these danger signs, there is undue tachycardia, disproportionate tachycardia. For every degree rise in temperature, you have a 10 beats highs. Whereas if there is a disproportionate tachycardia or a tachypnea or dyspnea, always do have a pulse oximetry in your clinic. Look for oxygen saturation. If it is less than 94, there is hypotension or shock. If there is a cyanosis, dehydration, drowsiness, dizziness, coma, or a severe abdominal pain, or seizures, or cold peripheries, prolonged CRT, capillary refill time in young children, normally it is less than 3 seconds. If it is more than 5 seconds or 7 seconds, any of these danger signs immediately means this patient needs immediate admission, isolation. If you have a clinic, refer them early. This is called category C. The mortality is extremely high. If you don't do all these 6 at the same time, refer them, admit them, isolate them, keep them in ICU. On one hand, do tests, another hand, give treatment, intimate the health authorities. All these 6 has to be done at the same time. The lab test, as I told you, it is not a blood test. It is a reverse transcriptase polymerase chain reaction. Younger children less than 6 months, nasal swab. Older children, throat swab. Adults, throat swab. Start on Oseltamivir early, ideally before 48 hours. Once again, I want to insist, in bird flu, it is double dose, 150 milligram BD. Normally, in a ordinary seasonal flu, it is 75 milligram BD for adults. In bird flu, 150 milligram BD for 10 days. The mortality is high due to secondary bacterial infection. You need to start on 3rd generation cephalosporin in all cases, anticipating fatal complications like ARDS, pulmonary pneumonia, pulmonary sepsis. Having seen this, if you look at the lab features, many a times this X-ray, if you take an X-ray, bilateral symmetrical infiltration mimicking ARDS will be there, nearly to the tune of around 40% of them. So this is also clue, but many times the CBC will be normal. Do not go by CBC. As per New England Journal of Medicine, the ideal time to start any antiviral, particularly Oseltamivir in influenza, is within 48 hours. But in practice, we do have children coming to you on third day or fourth day. So whenever you see them, whatever the benefit they achieve, you can start the Oseltamivir even if they come late to your practice. But ideal is 48 hours. Okay. This dosage recommendation, please remember, as I told you, in young children, usually the dose is 2 to 3 milligram per kg weight. Usually, Oseltamivir is contraindicated in neonates, particularly less than 14 days. Actually, you need to give double the dose for a longer duration because the viral clearance is low in children and the viral excretion also is for a longer time in children. In order to reduce the spread of virus, it is given for a longer time. Suppose if you have a suspected case and you have got contacts at home, you need to give this chemoprophylaxis. If it is an adult, you have to give 75 to 150 milligram OD for 10 days. So that's called chemoprophylaxis. To the contacts of those positive or suspected cases, you need to give chemoprophylaxis OD for 10 days. The most important message to the public, what you need to convey is that when you see a sick bird or a dead bird, do not touch them. Do not handle them. Do not feed them. Inform the authorities, corporation authorities. That's very, very important. So, if there are poultry workers in your patients or corporation workers or zoo workers or veterinarians, always ask them to wear PPE, particularly a poultry worker where they have got suspected bird flu. They have to wear goggles, they have to wear that N95 mask, they have to wear the gloves, full apron like in COVID ward. They have to wear everything because once the virus enters to them, the mortality is very high. So for doctors, very, very important, two important things. One is whenever you see any patient suspected fever, first make sure it is viral or bacterial. If you think it is viral, first make sure it is ILI or non-ILI, influenza-like illness. If you think it is ILI, you take a proper history, take all the travel history, everything which I told you, 6 points, and then define the case as suspected bird flu, because by just defining them, you can reduce the mortality from 50 to 60% to 0%. So doctors are very, very important. You have to act shrewd. So please tell the public who come to your clinic, do not believe in rumors. That's very, very important. And do not panic. These two words are very, very important. It should come from the mouth of all the doctors who attend this CME. Sometimes people ask me, though the birds are dying, hundreds, thousands of birds have died, why human, we have not got that virus? This virus has got affinity for avian alpha-2, 3 receptors in the respiratory epithelium. Fortunately, human beings, we got only 2,6 receptors. So the affinity attachment is very less. That's the reason we escape many a times getting avian flu from the birds. But still, we have to be very, very careful. If you give an opportunity, the virus will enter. That's very, very important. And please remember, you have to educate them to not to take unboiled or half-boiled egg. Sorry. Avoid uncooked or undercooked food. This virus is
Sir, please take some time, sir. Please
yeah.
please take some time, sir. We'll wait for your turn.
Oh. Yeah. This virus is heat sensitive. it is killed at 70 degrees boiling. Normal boiling, all the virus will be killed. So always you take whatever, whether it is chicken or mutton or egg, always cook it and eat it. And for the veterinary people, you should not do necropsy for these dead birds. It has to be done in assigned labs. And if at all, if you bury these birds, it has to be 10 feet depth to avoid spreading to other. And if there is a suspected bird flu in a poultry, all the birds has to be culled. They have to be buried 10 feet. Coming to the very, very important slide. Luckily, we got a wonder drug by name Oseltamivir. It is Neuraminidase inhibitor. It's a drug of choice for both for a simple seasonal influenza and also for bird flu. But the only thing is we need to give for a longer duration and a higher dose. Normally, we give 75 milligram BD for 5 days in adults in a seasonal flu, whereas in a bird flu, you need to give 150 milligram BD for 10 days because of the slow viral clearance and prolonged shedding, particularly in young children. There is a wonder drug, single dose drug called Baklava. It's a polymerase inhibitor. It's not available in India. It's available as Zofluza in USA. It is given for adults and children above the age of 12 years. Inhaled drug Janamavir is there. For mild bird flu, you can give. For severe bird flu, it is not useful. Whereas the patient is sick, you can use IV Perimivir. Most important message is many times doctors and patients ask me, I'm taking this season flu vaccine regularly. Will it protect H5N1? The answer is no. It will not protect against H5N1. It will protect against H1N1, H3N2, influenza B, not against H5N1. Regarding this monovalent H5N1 vaccine, at present there are 2 vaccines, Ordance and Ariprex in USA, Canada, specifically for high-risk persons. There is no such vaccine available in India. There are some vaccines in the pipeline. Government of India is giving a thrust to that. Maybe in years to come, we'll get it. Important message is sometimes our own colleagues, we misuse or overuse antibiotics. Now we are celebrating Antibiotic Awareness Week. If you misuse Oseltamivir or overuse it, maybe we will be celebrating Antiviral Resistance Week. So antimicrobial resistance is high. You have to use it, Oseltamivir, in correct patient, the correct dose, correct duration. Do not overuse or do not misuse. So let me come to the last slide. Please remember H5N1 is diagnosed clinically sitting in your 10x10 chamber. If you have a high index of suspicion, take RT-PCR and give Oseltamivir early. You can reduce the mortality to practically zero. Do not panic, both for the public and doctors. It is a virus to respect. Please remember, the danger lies not in today's virus, but in ecological and human behavior by doctors and also public that allows the virus to persist, amplify, and potentially become lethal. If you act smart, if you act scientifically, you can bring this H5N1 to under control within by ourselves. With that, I like to thank you. Before I thank you, I take this opportunity to thank the IMA of Tamil Nadu State, the State President Dr. Sridhar Sir, and the State Secretary Dr. Thiraviya Mohan, and Dr. Solomon, and also the IMA CGP Tamil Nadu wing, Dr. Madan Mohan, Dr. Srinivasan, and Dr. Nandakumar, for giving us opportunity to conduct this 6th batch of infectious disease in fellowship certificate course, which is going to commence on 22nd March. We got 10 TNMC credit hours. So if you are interested, you can contact me. If you want the slides, the bird flu slides, you can contact me. If you want to join this course, you can contact any of the office bearers, including the state president or the CGP team or me. We'll be happy to make you a member of this infectious disease certificate course. Because friends, I must appreciate at this juncture, I must appreciate our Coimbatore president, Dr. Kosal Ram sir, Parameshwaran sir, and also Coimbatore CGP team, Dr. Karthikeyan sir, Dr. Babu sir, for initiating this bird flu CME. Before the pandemic happens, CMEs will be arranged through this FCAD course. So once again, I like to thank the Coimbatore's IMA and also CGP wing of Coimbatore for giving us this opportunity. So friends, if you are interested to get the slides, please send a request to me. You can note down my number 98422 11179, 98422 11179. So friends, followed by this talk, we got two important senior persons. One is retired Director of Public Health, Dr. Kulandeswamy, who is also the founder and the backbone of Fellowship Infectious Disease Certificate course, who will be joining with me for this question and answer session. And also highly accredited academician, Dr. Farooq Abdullah, my close friend. We all three of us will join you for answering your FAQs, frequently asked questions. I request Dr. Karthikeyan sir to take over the podium and to conduct this.
Yeah.
Thank you.
Thank you, sir. Thanks a lot, sir.
Yeah.
It was a very enlightening lecture for on this day, and we had definitely an enlightening lecture, and we had got cleared many things, and we have to have further few queries, which we will be also talking to two other important speakers, Dr. Kulandeswamy sir and Dr. Farooq Abdullah sir. And at this point of juncture, I would request our state Joint Secretary of IMA CGP Wing, Dr. Srinivas, who is also there in the Zoom meeting. Sir, Dr. Srinivas, sir, are you there?
Yes, sir. Yes, Karthikeyan, sir.
Karthi, before that, just want to give a comment. It was Dr. Balamurugan from Coimbatore IMA.
Yes, sir. Yes, sir.
Wonderful talk, Neminathan sir, as usual, and good to connect Kulandai and Dr. Farooq Abdullah. Yeah, please continue. Thank you.
Thank you, sir. Thank you, sir.
Dr.
Dr.
Karthikeyan.
Srinivas, sir.
Yeah.
Yes, sir.
Yeah. Thank you very much, Coimbatore IMA and the presidentship of Dr. Koshal Ram, Secretary Dr. Parameshwaran, and the Finance Secretary Dr. Balamurugan sir, the CGP team chairman Dr. Karthikeyan, and the Secretary Rajesh Babu sir for organizing such an excellent program. I wish to thank you all on behalf of the Coimbatore IMA as a secretary-elect and as a part of the state CGP, as a joint secretary of the state CGP. I would like to thank you all for organizing this. I was about to tell about this FCID, Fellowship Certificate of Infectious Diseases course, for which our course coordinator is none other than our Dr. Neminathan with his expert panel. He has run 5 batches successfully, and we are launching the 6th batch. And we have a FCID interested doctors group. If you are interested, you can send message to any of us. We'll send you the link, and from there we'll guide you how to join the course and how to proceed along. And also, our CGP wing is starting a diabetology course in the next week on 18th, and the diabetology food course. Interested candidates can definitely contact either the local branches or the state CGP team. We'll be definitely guiding you to joining all the courses. We have got diabetology, diabetic food, infectious diseases courses, and we have got a pulmonary respiratory course. We have also got a neuro course, and lots of courses are there in the pipeline. So definitely all of you who are non-members, I see many of them in the chat writing as non-members, please do join the IMA. It is for your safety and your betterment. We are advising you to join our parent association, be it whichever specialty you are, and then also join the CGP and also join the courses, whichever courses you are interested in. Thank you, Dr. Karthikeyan. It was a well-attended meeting. And thank you, Neminathan, sir. It was doing a good job.
Thank you, sir.
As usual, you attract crowd. It's doing good. Thank you, Dr. Karthikeyan. Over to you.
Thank you, sir. Thanks a lot, sir. So, without any delay, we will go to the panel discussion. Along with Dr. Neminathan, sir, 2 other panelists are Dr. Kulandeswamy, sir, who is very well-known person. He joined his government service in 1993 and held various posts as Deputy Director of Health Services at Vellore and Theni, as Deputy Director, Joint Director, Additional Director, and Director of Public Health and Preventive Medicine till retirement in 2020. Even after his retirement, he was and he is continuing his service as a technical advisor and state task force member for COVID-19 management. And presently, he is the chairman in KMCH Institute of Allied Health Services, Coimbatore. He has received Best Doctor Award from Tamil Nadu Medical Council and IMA Tamil Nadu. And he has also presented many papers and conferences and in various articles also he has published, particularly like vaccine cold chain system in India, behavior of dengue viruses during outbreaks, etc. Another speaker who is also a very talented person, Dr. Farooq Abdullah. He is working as the senior assistant professor in Department of Pharmacology, Government Ramanathapuram Medical College, also practicing medicine at Sivagangai. He has joined government service in 2013 after his graduation from Government Vellore Medical College and post-graduation from Tiruchi SRM Medical College. He is known for his articles published regularly in the magazines and newspapers in relation to infectious diseases and epidemics. He is an expert content writer in Vigadan and Hindu magazine. He has also authored many books in the lifestyle of modification, including low carbohydrate diet, mental health, etc. He is also a social activist and a philanthropist. He was also awarded with a Humanitarian Doctor Award, and he is one of the author in Tamil Nadu State Government's ambitious program, MBBS in Tamil, and translated standard textbooks and created Tamil new books in Tamil. He has also received Asan Award from our IMA Tamil Nadu State branch. So we will go to our panel discussion. Sir, first we'll start with Dr. Kurandesamy, sir. Sir.
Yeah, good evening to all of you. Thank you for your kind words. Please.
Slide sharing stop பண்ண சொல்லுங்க.
Audible?
Sir, Neminathan sir, can you please stop sharing your slides, sir? Thank you, sir. So we'll start with Dr. Kurandesamy, sir.
Yes, sir. Yes, sir. Please.
The first we would like to ask is how do wild migratory birds function as the primary reservoir for H5N1, and what specific pathways allow this virus to jump from wild populations to domestic poultry and subsequently to the humans?
Yes, it's very important to know how these viruses behave, and the jumping of the viruses from one area to another area that is spreading, and jumping from one species to another species. Sometimes they jump the species barrier also. So if we carefully look at the migratory birds, they take the infection globally. So now the country is spared from this avian influenza, particularly the H5N1. H5N1 and H7 and N1, and they are the highly pathogenic forms. So they go to, when they have a chance, that is the captive birds, that is the poultry, organized poultry is captive birds. The other poultry is backyard poultry. So then it spreads from the migratory wild birds to either the poultry or captive poultry or the backyard poultry. Variety of birds are affected. Rarely, even the crows are affected very rarely, but now in the Chennai and certain other places, even these rarely affected birds also, this is what is the virus gets adapted to different situations. As we know, all the influenza viruses, they have the notorious capacity to various kinds of antigenic drift, and they change their pathogenicity so that they can keep spreading. And from there, it spills over to usually pigs. Then the pigs act as the intermediary animal. So from pigs, it may come to humans, it may go to the other, including the farm animals. So this is how the migratory birds, they bring the infection. So that is why in zoos, if you look at very carefully, so all the birds, they design in such a way that outside birds do not have any entry into zoos, And even the poultry also the same way. But backyard poultry has access to the mixing of these viruses, and also large water bodies where these migratory birds come, and the infection is transmitted to other animals. This is how the infection spills over into the community.
Thank you, sir. Thank you,
sir.
Dr. Kulendeswamy, sir. Sir, for this valid input. I think your years of expertise in this epidemiological field, you can give us a clear picture. Thank you for giving this, sir. Thank you so much.
Thanks, sir. The next question is Dr. Farooq Abdullah, sir. Sir, in treating seasonal flu, Oseltamivir therapy is given only for 5 days, but current guidelines for H5N1 suggests extended therapy for up to 10 days. What is the reason behind that, sir?
Am I audible, sir?
Yeah,
yes, sir, you are audible.
Yeah.
Please go ahead, sir.
Yeah, first of all, my sincere thanks to IMA Coimbatore for inviting me for this wonderful session to take part with along with the stalwarts of public health, Dr. Kulendeswamy, sir. நான் எப்பயும் சொல்லுவேன் எனக்கு அப்பாயின்மெண்ட் போட்டவரே சார் தான். அதுக்கப்புறம் டாக்டர் நெபி சார், இன்ஃபெக்ஷஸ் டிசீஸோட ஸ்டால்வார். இவங்க கூட எல்லாம் வந்து விராட் கோலி, ரோஹித் சர்மா கூட சூரியவன்ஷி இறக்கி விட்ட மாதிரி என்னையும் இறக்கி விட்டுருக்கீங்க. தேங்க்யூ வெரி மச். டாக்டர் கோசல்ராம் சார், டாக்டர் பரமேஸ்வரன் சார், டாக்டர் கார்த்திகேயன் சார் அண்ட் டாக்டர் ராஜேஷ் பிரபு சார், எல்லாருக்கும் நன்றி. ஸோ சார், நெமி சார் ஆர் ஆல்ரெடி discussed that H5N1 is not like H1N1. H5N1 is an aggressive virus producing aggressive disease. என்ன H1N1க்கும் H5N1க்கும் என்ன வித்தியாசம்னு பாத்தீங்கன்னா, H1N1 harbors more in our upper respiratory tract. So it is more infectious and less lethal, while H5N1 harbors more in our lower respiratory tract. அதாவது லங்ஸ்ல தான் வந்து அதிகமா அது பெனட்ரேட் ஆகும். It spreads slowly but often fatal. So we need an extended duration of therapy with Oseltamivir. As sir Nemi sir has rightly mentioned that we need double the dose, 150 milligram twice daily for up to 10 days. While in seasonal influenza, we treat it for just 5 days. அதுக்கு சார் என்ன சொல்லியிருந்தாங்கன்னா, it replicates more deeply in the lungs than seasonal flu because it binds more with alpha 2,3 linked sialic acid. அது எங்க இருக்குன்னு பாத்தீங்கன்னா லங்ஸ்ல தான் இருக்கு, இந்த alpha 2,3 linked sialic acid. So if treatment stopped within 5 days, நம்ம எப்பயுமே இந்த ஆன்டிபயோட்டிக்ஸ் எல்லாம் எடுக்கிறது பாத்தீங்கன்னா ஒரு அரைக்குறையா எடுப்போம் இல்லையா, அது மாதிரி 3 days 5 days எடுத்தோம் அப்படின்னா there will be a rebound shoot where severe inflammation and damage can occur. So for treating H5N1, we have to be damn sure about diagnosis. If the diagnosis is damn sure, you have to treat it for at least 10 days for prolonged suppression of virus. Thank you.
Thank you, sir. Now we will ask Dr. Neminathan sir. Already he has highlighted, but we would like to get more inputs from Dr. Neminathan sir as well.
Yeah.
Sir, in children, H5N1 often presents with high fever and lower respiratory tract symptoms. However, what are the distinct extrapulmonary manifestations seen in pediatric cases that differ from the typical seasonal influenza?
Yeah, it's a very good question. So as I told you, whenever you get a child with fever, you have to make sure whether it is viral fever or a bacterial fever. Once you made the diagnosis of viral fever, you have to make sure it is a respiratory viral illness like influenza or a non-respiratory like dengue. Having made a respiratory viral illness, you have to identify which is the virus. I told you 7 viruses are there. All these 7 viruses, though they have a common pattern, suppose there is a child with a young child with a stuffy nose, it's probably rhinovirus. If there is a little older child with a barking cough, probably it is a croup, it is caused by para-influenza. Little older infant having a cough, breathlessness, feeding difficulty, it is bronchiolitis due to RSV. So similarly, by making a proper diagnosis can be made just by using your knowledge, what you have studied in your anatomy, pathology, physiology, in your undergraduate curriculum, arrive at a diagnosis. Particularly when coming to H5N1, the extrapulmonary manifestations are high because, as I told you, they can not only affect the respiratory epithelium, lower respiratory epithelium, they got affinity for the GA epithelium. So most of the time they come to you with abdominal pain, with a sore throat and a cough, and many times they do have vomiting. So in those cases, you have to be doubly careful. One is because of the disease per se, there will be abdominal pain. Or your Oseltamivir also will worsen the abdominal pain. You have to be very, very careful. many times they come to you with pink eye, conjunctivitis, and sometimes they do have a unilateral epistaxis. As a ENT physician, you will agree with me that unilateral epistaxis in a child with a respiratory illness, we have to think of adenovirus or influenza. So these things you have to keep in mind. The most important thing is, as I told you, they progress rapidly progressing ARDS, pulmonary pneumonia, sepsis. They go going for encephalitis. Sometimes, many of the time, these children during influenza season, they come to you with febrile seizures. In our hospital, 25% of the febrile seizures are due to influenza, seasonal influenza. They have neuropredilection also. So these things differentiate from the normal influenza. So you have to look at these three sites: eye, nose, GI, and the brain and the heart. These 5 places. Yeah.
Okay, sir. Thank you, sir. As you told, it is a multidisciplinary specialist approach. So everybody should be aware of this. Thanks, sir. Thanks for the input. And all the specialists have to have an idea of this bird flu. So the next question is for Dr. Kulandai Sami, sir. Sir, why influenza-like illness surveillance is important, sir?
This is a very, very important question. Many times the syndromes, like influenza-like illness, acute diarrheal disease syndrome, ADD syndrome, then acute flaccid paralysis, AFP, and then jaundice syndrome, then acute encephalitis syndrome, unusual syndrome. So these kind of syndromes have epidemic potential, or sometimes even the pandemic potential. So that is why when the COVID-19 came, so Tamil Nadu had already the system is in place. AES surveillance as well, the ILI surveillance was in place. So it became very easy to identify the infection at the earliest. That is a very important. So that is why, because the same syndrome is caused by a variety of viruses, influenza-like illness. So although it is caused by a variety of viruses, so the management, the clinical management and the epidemiological significance are almost similar. So that we know that these cases have to be investigated properly, and the samples, laboratory samples have to be taken and sent to for confirmation. So that is the reason we advocate the syndromic surveillance for doctors, particularly the pediatric and medicine and other centers. So with regard to add on to Dr. Farooq, with regard to Oseltamivir, it had been earlier when the swine flu epidemic happened, it was in Schedule X drugs. Only the pharmacies which are having Schedule X have to are permitted to stock this Oseltamivir. But subsequently, we made an effort to see to that it has been transferred to Schedule H category. So now the Oseltamivir, it has a very long expiry also, 5 years, 6 years also expiry. So any pharmacy can store a minimum quantity of Oseltamivir. The pharmacies in major hospitals, they can store a reasonably good quantity. And H5N1, the ordinary H5N1 that mostly affects the poultry, but in that also there is another variety called highly pathogenic variety. So when it is confirmed as a highly pathogenic variety, so various the protocols, the Government of India protocols, that includes the Forest Department, Animal Husbandry, Veterinary Department, Health Department, so local administration, they all alerted and they will take action. So with reference to Oseltamivir prophylaxis, that varies. So that sometimes it is extended to even the contacts, the community contacts, it is even extended up to 3 weeks, the prophylaxis. If it is an highly pathogenic, then the prophylactic, usually the treatment dose, half of the dose is given as the prophylaxis. But here, the same treatment dose is continued for the prophylaxis also. So it is very important to carefully read various the media reports and our WhatsApp and our continuing medical education channels. So what is the specific diagnosis of that particular avian influenza in a particular area? And accordingly, we have to change our treatment protocols, adapt and modify our treatment protocols.
Thank you, sir. The next question is for Dr. Farooq, sir. Now, because of the availability of the Oseltamivir, so Oseltamivir resistance is becoming a global menace. Will it become a hurdle in our therapy against H5N1 also, sir?
Really, the resistance against Oseltamivir is mainly due to a mutation which is happening in the virus. In H274Y mutation is the very notorious mutation happening in the virus, which causes Oseltamivir resistance. It typically causes a structural bump in the Neuraminidase portion, where there is a mismatch or a misdocking happening between a Neuraminidase and Oseltamivir. So for a good susceptibility, Oseltamivir has to dock well with what is called Neuraminidase of the virus. But this particular H274Y mutation will reduce the affinity of Oseltamivir by 400 folds, thereby reducing its therapeutic efficacy by 900 folds. Treatment வந்து சுத்தமா வேலை செய்யாத மாதிரி ஒரு மியூட்டேஷனா அது வந்து வளர்ந்துட்டு வருது. In humans, of late in 2024 and 25, Oseltamivir resistance is noted in North America, in particularly D1.1 strain. But இப்போ வரைக்கும் அது ரேரா தான் இருக்கு. That is a very good news. In animals and birds, resistance is still rare. But in future, இந்த மியூட்டேஷன் இருக்கிற அந்த வைரஸ் வந்து ப்ரொபகேட் ஆகும் பொழுது, வைல்டு பேர்ட்ஸ் ரொம்ப அதிகமா பரவும் பொழுது, இந்த குறிப்பிட்ட மியூட்டேஷன் அதிகமா பரவி, அதனால Oseltamivir resistance may increase in future.
Okay, sir. Dr. Neminathan, sir, already you have highlighted, but even then we want to get a clear idea from you. Why are previously healthy children and young adults at a higher risk for severe H5N1 complications compared to the elderly? And what role does the cytokine storm play, sir?
Yeah, as I told you, their surface area is very high when compared to the body weight. And they are also children, they don't know what is hygiene. They go to the backyard, they play with the birds. And even if some sick bird is there, they handle them. So they don't wash their hands, they touch their face. And the chance of getting this any zoonotic disease very high in young children. And also these children do have a high risk of cytokine storm because of the immunological immune dysregulation fever, that's called. So even during COVID times, though the number of COVID in pediatric cases were low, the incidence of MIS-C was high. So multi-system inflammatory response to the disease was high because of the cytokine storm. Because of these three reasons, the mortality morbidity is high, particularly in pediatrics.
Okay, sir. Dr. Kolandasamy, sir,
Yes.
the World Health Organization has historically reported. Excuse me, please. Rest of the participants, please mute yourself, please. Dr. Selvaraj.
Dr. Selvaraj, please mute yourself.
Dr. Selvaraj,
Selvaraj, please mute yourself. Dr. Selvaraj.
Yes, done.
Dr. Kolandasamy, sir, the World Health Organization has historically reported a case fatality rate exceeding 50% for H5N1. Is H5N1 is a dreadful disease to panic, or be missing something?
It is definitely a dreadful disease to panic because it has the pandemic potential. But because of the certain inherent properties of the virus, so although it jumps, still it takes time. If we take the history of the Kerala, so frequently we get the reports that the poultry are culled 3 kilometers are demarcated as a no entry zone, and another 10 kilometers are the safety, the buffer zone kind of things. But fortunately, the number of cases infected, the humans, and the cases spread long. Even the vehicles which are, when we go to an affected area, so the vehicles, we have to leave the vehicles outside and we have to take proper precautionary measures and including the shoe covers. Then we have to go to the area and there are a lot of protocols are there. We have not seen large scale spread. It continues to be locally restricted to particular area. But even then, it has the potential to escalate into major the national or international the pandemic proportions. But still, it is not happening. But the main issue that we need to promote among the general public as well, particularly in the government. So if you look at the facilities for diagnosing, we'll have all kinds of virological diagnostic facilities. Even all our government medical colleges in Tamil Nadu, we have virology lab, regional virology lab, and apex virology lab. But unfortunately, and all of them are trained very well in National Institute of Communicable Diseases, Pune, and other places, including the Bhopal animal, where the higher center for the specialized center for diagnosing the various kinds of infection as part of the One Health program. But unfortunately, the reagents, the cost, the availability of particularly the diagnostic kits is very scarce. So the finally arriving at the cause of the causal factor, the microbiological organism. We had undertaken a study in Nilgiris and Krishnagiri district with the Manipal collaboration with the Manipal. It's a very intensive program. We are able to identify the causative organism only in 55 to 60% of the fever cases for whom the samples are collected from these two districts. Then I was literally shocked when we inquired what is the situation in other higher institutions in the country. Then we were informed, we were surprised to know that it was the highest in the country. This 55% was the highest in the country, clearly indicating we are managing cases, most cases by syndromic approach. We are not fixing the causative. So there is and similarly the bat surveillance. Even in Canada and America, the bats transmit rabies. But are we having a bat surveillance in India? Still, we are yet to institute a bat surveillance in India. So only when some diseased birds are noted, these bats are brought into the high security laboratories and they dissect it and they take samples and diagnose it. It is not done as a matter of routine. But for plague, every month, even in Tamil Nadu, from Talavadi to Osur, every month around 200 rats are collected. The spleen, liver, and the serum are taken and sent to Bangalore laboratory, whether the plague is any antibodies are noticed in the rodents, in the wild rodents. But that kind of surveillance is not uniformly carried out in humans as well as in animals and birds for the diseases which have the pandemic or epidemic potential. So definitely, in my opinion, we are missing something.
Okay, sir. So, Dr. Farooq, sir, regarding use of Oseltamivir in H5N1 special population, is there a specific restriction or caution to be noted? Farooq, sir?
Sir, am I audible,
Hello.
sir?
Yes, sir.
Yes, sir. Audible, sir.
So, regarding use of Oseltamivir in special population, especially in pregnancy and postpartum, it is a very safe drug. It does not increase the risk of outcomes of pregnancy, or it is not a teratogenic drug. So, we can effectively use Oseltamivir in pregnancy as well as postpartum. With regards to kidney disease, we have to be careful when EGFR falls below moderate level, 31 to 60 ml per minute. We have to reduce the dose to 30 milligram twice daily, as Oseltamivir is having primarily renal excretion. When it is a severe renal disease, comes to 11 to 30 milliliter per minute of EGFR, we have to give 30 milligram once daily Oseltamivir. If it is less than 10 ml, Oseltamivir is usually not recommended. If the patient is on hemodialysis, we can give 30 milligram after each dialysis session. For breastfeeding mothers, a very low quantity of 0.5% is getting excreted through breast milk, so it doesn't go to father infant. So we can safely give Oseltamivir in breastfeeding mothers also, and mother can safely continue breastfeeding because it also benefits transfer of antibodies to infant. Regarding heart disease, H5N1 is a notorious disease which can cause severe viral myocarditis. So we have to be very careful in admitting the patient with heart disease, and we can effectively give Oseltamivir. And in patient taking blood thinners like warfarin, we have to watch for slightly increased bleeding risk when you give in high dose for a prolonged period. In liver disease, standard dose can be given for mild to moderate liver disease, but for a severe liver disease patient, we have to be careful in monitoring hepatotoxicity. Thank you.
Okay, sir.
Thank you, Dr. Falu. Being a pediatrician, I see many pediatricians join this conference. Please remember, Oseltamivir is not to be given in neonates. In those cases, what you can do is you can give Oseltamivir to the mother, and whatever is excreted through breast milk will act as a treatment chemoprophylaxis for the baby. So the advantage is that you can treat the mother, through the breast milk, you can treat the neonate also.
Okay, sir. Okay, thank you, sir. Neminathan, sir, in the Indian pediatric context, what are the primary differential diagnoses a pediatrician must consider when a child presents with H5N1-like symptoms? And what is the risk of bacterial co-infection?
Yeah, as I told you earlier, many of these viruses, they have the same, exhibit the same syndromic presentation. So neither the patient nor the doctor knows whether this is particularly influenza, particularly whether it's a seasonal influenza or a bird flu. So only thing is, I told you about the 6 cardinal questions that you need to ask in your patient, every patient. If one of them is positive, probably it is probably H1N1. But still, high index of suspicion you have to keep in every other patient. So the first commonest DD is your seasonal influenza. Of course, both of them need the same drug of therapy. So start with Oseltamivir if there is a comorbidity or a danger sign, and admit them. On one hand, take a RT-PCR, another hand, give Oseltamivir. That's number one. Next important differential diagnosis, particularly H1N1, I told you it causes conjunctivitis. One common virus that causes conjunctivitis, respiratory and GE symptoms is adenovirus. Adenovirus is a great mimicker of bacterial infection. In adenovirus, you can have a purulent conjunctivitis, you can have a cough, cold, watery diarrhea, abdominal pain, joint pain, all those things will be there. If we do CBC, counts will be high, it will be 15,000, 18,000. Polys will be high, CRP will be high. If you do urine microscopy, puzzles will be there, more than 10 puzzles. If you do a culture, be negative. So that's called sterile pyuria, like Kawasaki. So adenovirus is a great mimicker of bacterial illnesses. So if you suspect adenovirus also, if adenovirus usually comes in bouts, it comes as a couple of months back, all children had conjunctivitis syndrome, pharyngoconjunctivitis syndrome. So those cases, you have to think adenovirus. And you have to always think about, because of the extra-intestinal manifestation of H5N1, like nausea, vomiting, diarrhea, sometimes hepatomegaly, you have to keep dengue always in the back of the mind. Dengue is a disease that is always prevalent in all parts of the country throughout the year. So you have to always keep dengue in the back of the mind. The child is really sick, you keep the child inside and start on normal saline. Look for intravascular dehydration. Always keep monitoring the hematocrit. Just you have to be very, very careful about the intravascular dehydration. So you have to monitor the urine output, pulse pressure. You have to monitor the hematocrit. That is very, very important. Just don't think as flu and then miss dengue. That's very, very important. Another important aspect that you need to keep in the mind is chikungunya. Chikungunya is nowadays coming to the surface. Lots of chicken cases we do see in our OPD practice. If there is a bilateral symmetrical minor joint involvement with severe pain, you have to think of chikungunya. Please keep that in the back of the mind. And usually in H5N1, it is the anti-gravity muscles, calf muscle pain. Child be lifted and brought to you on the table. So there is a muscular pain, particularly the anti-gravity muscles, probably it is H5N1. And bacterial pneumonias are very high, particularly in H5N1. As I told you, the secondary bacterial infections are nearly 25% of these children with severe flu get bacterial illnesses. So whether you suspect flu or pneumonia, you hit them hard with 2 drugs. If it is a sudden abrupt onset, probably starting like a flu, then turning out to be bacterial, give oseltamivir and also don't hesitate to give IV antibiotics. That's very, very important. It's very difficult to find out whether the organism is bacterial or viral. Many of the organisms are fastidious, you will not grow them in the culture. So hit them hard with 3rd generation antibiotic. That's very, very important. So the crux of the matter is high index of suspicion should be there, and start oseltamivir early, and then always do not withhold antibiotic, particularly in flu.
Okay, sir. Thank you, sir. Kulandasamy, sir, beyond direct contact with the sick poultry, what are the primary environmental risk factors that can facilitate indirect transmission to humans, sir?
Yes, the direct spread is only from the poultry to birds to humans. Then another one is human to, it has the human to human transmission potential also there. It becomes very dangerous. For, like any other influenza, like illness or influenza virus, the hand washing is very, very important. Hands, through hands, it will definitely spread. And also the sick birds, so they continue to excrete the virus for several days, almost about 10 days. The birds, either they survive or the birds, they die. The survived birds will continue to spread the disease through the, mostly through the excreta. So then, so anybody who is handling, touching, and the poultry workers, the poultries have to maintain a minimum standard. They have to leave everything. They have to take a bath. They have to wash, and then only they should be. That practice has to be enforced in the poultry, but that is not being done. So, and also similarly in the wet markets, say where the birds are being sold. So there also the birds which are coming from the backyard poultry, the birds which are coming from the captive poultry, everything are mixed in a single place. So again, that is jumping from one species to another species also is very possible. So hand hygiene, then respiratory hygiene. These are the 2 important things that we have to follow, like for any other influenza virus.
Okay, sir. Farooq, sir, as oseltamivir resistance is growing, do we have drugs other than oseltamivir against H5N1 in armory?
Yeah, I will elaborate about what are all the drugs which are currently available against treating H5N1. Hope you all know that Neuraminidase inhibitors are gold standard against H5N1. Adala Oseltamivir is the primary first line drug, which is the oral drug. That's a beneficiary and the most evidence-based medicine in reducing mortality. While cons என்னன்னு பாத்தீங்கன்னா Oseltamivir resistance, but இப்போதைக்கு அது rare. Futureல அந்த mutation ரொம்ப grow ஆகும்போது it can become a menace. If you suspect Oseltamivir resistance, second line drug Zanamivir is available in inhalational form. அது வந்து ரொம்ப ரேரா தான் இங்க நமக்கு அவைலபிளா இருக்கு. Then intravenous only for hospitalized patients we have Paramivir. Who cannot take oral drugs. அதாவது GI complications ரொம்ப ஜாஸ்தியா இருக்கிறவங்களுக்கு we can use Paramivir. Then second class of drugs we have cap dependent endonuclease inhibitors, Baloxavir, Marboxil. இது வந்து USAல அவைலபிளா இருக்கு, பட் இந்தியால இல்ல. Pros வந்து it is oral drug and it is a very single dose drug. It can be combined with Oseltamivir in critically ill patients. And our age-old drugs like amantadine, rimantadine எல்லாம் வந்து already influenza A, H1N1க்கே வந்து resistant ஆயிடுச்சு. அதனால இப்போ we can't use it for H5N1. And recent advances in pipeline பாத்தீங்கன்னா இந்த polymerase inhibitors, அது Onradivir, TC42344 இதெல்லாம் வந்து phase 2 trialல இருக்கு. Viral decoy inhibitor NV387 and another neuroimmunidase inhibitor CD388 இது எல்லாமே வந்து பேண்டமிக்கை வந்து ஆன்டிசிபேட் பண்ணிட்டு இருக்கிறதுனால பேண்டமிக் ரெடினஸ் ப்ரோக்ராம்ல we are all these drugs are in pipeline. It will be available in another few months or in another 1 year.
Okay, sir. Neminathan, sir, one query from the chat box.
Yeah.
Role of steroids to downstage the immune reaction. Is there any role for the steroids to downstage?
Please remember, steroid should never be used in H5N1. That's very, very important. That's a red line statement from WHO. It should never be. The steroids increases the mortality in H5N1. When there is a cytokine storm, if you got evidence, you can use that. But if there is sometimes we do see fever persisting beyond 5 days with high-grade fever, with hypofibrinogenemia, with other markers of like HLH-like features. In those immune dysregulation fevers, steroids can be used, but you must have an evidence. But for practitioners, steroids should not be given for any viral illness, particularly influenza. That's a carry-home message.
Okay, sir. Thank you, sir. Kurandasamy, sir. In India, nearly 30% of poultry production comes from the backyard farming. Why does this sector represent a higher epidemiological risk for H5N1 persistence compared to the large-scale commercial poultry producers?
Yes, as I have already explained, the captive birds, they are kept under close, the wild birds, the migratory birds and wild birds, they do not have, normally usually they do not have access to the wild, the poultry, captive birds. But the backyard poultry, so these birds, on the trees, the wild birds and other birds, they come and sit on the trees and they fly back and they drop their excreta. So then the backyard poultry also gets infected. So this is how the backyard poultry is has a higher risk than the captive poultry.
Okay, sir. Farooq, sir, this one is already answered, but even then, we would like to get from your side. It's a popular phrase that H5N1 is in the verge of mutation away from becoming a pandemic. Is that true? If it is true, are we ready to tackle it?
சார் இதுக்கு வந்து நான் ஒரு அனலாகி யூஸ் பண்ணலான்னு பாக்குறேன். இஃப் பைக் டிரைவிங் தான் வந்து பேண்டமிக் அப்படின்னு நம்ம வச்சுக்கிட்டோம் அப்படின்னா, அதுல இருக்கிற இன்ஜின் அப்படிதான் வந்து இட்ஸ் அன் எபிலிட்டி டு சர்வைவ் அண்ட் ரெப்ளிகேட் இன் ஹியூமன் பீயிங்ஸ். அதுதான் வந்து இன்ஜின். அது இன்ஜின் மியூட்டேஷன்ஸ். கீ மியூட்டேஷன்ஸ் ஆர் இட்ஸ் எபிலிட்டி டு டாக் அவர் அப்பர் ரெஸ்பிரேட்டரி ட்ராக்ட். டில் நவ் H5N1 இஸ் அனேபிள் டு டாக் அவர் அப்பர் ரெஸ்பிரேட்டரி ட்ராக்ட். அது ஒரு முக்கியமான ஒரு மியூட்டேஷனா இருக்கு. தென் எ பைக் நீட்ஸ் ஸ்மூத் ரோடு டு டிராவல் வித்தவுட் எனி ஹிண்ட்ரன்ஸ். அதான் வந்து நம்ம ஃபார்மகோதெரப்பி. COVID-19க்கு வந்து நமக்கு தெரிஞ்ச ஒரு ட்ரக் இல்லை. பட் ஃபார் H5N1 இப்போ பேண்டமிக் வந்தா கூட நம்ம கையில வந்து வி ஹாவ் Oseltamivir, Paramivir அப்படின்னு Baloxavir நிறைய ட்ரக்ஸ் இருக்கு. ஸோ இந்த 3 மியூட்டேஷனும் என்னென்னு பாத்தீங்கன்னா, இந்த Q226L இட் இஸ் அ கீ மியூட்டேஷன் இன் HA ஹைலோரினிடேஸ் ரிசெப்டார் பைண்டிங் சைட்ல அந்த வைரஸ்ல நடக்கிற அந்த மியூட்டேஷன் வந்து இட் அலோஸ் virus to replicate in human upper respiratory tract. If the virus gets into upper respiratory tract, easier it will become more infectious. அதனால ஈஸியா வந்து அது ஸ்ப்ரெட் ஆகும். Then second one is called engine mutation, that is E627K. It happens in polymerase PB2. இது என்ன சொல்றாங்கன்னா mammalian adaptation marker. எந்த வைரஸுக்குமே இந்த E627K அது இன்ஃப்ளூயன்சா வைரஸ்ல நடந்துச்சு அப்படின்னா இட் வில் வெரி வெல் அடாப்ட் டு mammalian ஸ்பீசிஸ். இப்போ என்னன்னு பாத்தீங்கன்னா, நமக்கு வந்து கேட்டில்ல அடாப்ட் ஆயிடுச்சு, மெரைன் மேமல்ஸுக்கு அடாப்ட் ஆயிடுச்சு, இன்னும் ஹியூமன்ஸுக்கு மட்டும் இது அடாப்ட் ஆகாம இருக்கு. இட் அலோஸ் வைரஸ் டு ரெப்ளிகேட் இன் கூலர் ஹியூமன் அப்பர் ரெஸ்பிரேட்டரி ட்ராக்ட் when compared to birds core temperature. Then third one is we have already discussed in the smooth road. It is a resistance, it creates resistance to this Oseltamivir. So as of 2026 we have seen and encountered engine mutations. Already வர ஆரம்பிச்சிருச்சு. இந்த வைல்ட் பேர்ட்ஸ்ல இருக்கிற வைரஸ்ல எல்லாம் வந்து engine mutations வருது. We have not yet seen the key mutation. அது ஒண்ணுதான் வந்து இப்போ இருக்கு. So engine is waiting for key. So at present H5N1 it's more of a lower respiratory tract infection. அதனால அதிகமா பரவுறது இல்ல. So it is more of a highly lethal disease with less infectivity. பப்ளிக் ஹெல்த் ஆஸ்பெக்ட்ல என்ன சொல்லுவாங்கன்னா, மோர் ஆர்வம் இருக்கிற டிசீஸ் வந்து ஈஸியா ஸ்ப்ரெட் ஆகும், பட் லெஸ் லீத்தலா இருக்கும். கம்மியான ஆர்வம் இருக்கிற டிசீஸ் தான் வந்து பப்ளிக் ஹெல்த்தை பொறுத்த வரைக்கும் பெரிய பிரச்சனை. ஏன்னா ஈஸியா ஸ்ப்ரெட் ஆகிற டிசீஸ் தான் வந்து பெரிய பிரச்சனை. So in future, with acquiring key mutations, virus can gain ability to bind alpha-2,6 linked sialic acid in our upper respiratory tract, may become a highly pathogenic virus among humans and could trigger a pandemic. அதனால தான் வந்து ஓவரால் எல்லா நாடுகளுமே வந்து பேண்டமிக் ரெடினஸ்ல H5N1 வந்து ரொம்ப ஒரு முக்கியமான பிளேஸ்ல வச்சிருக்காங்க. இட் இஸ் லைக் அவர் சிட்டி ரோபோவா தான் இப்ப இருக்கு. அதனால நம்ம சிட்டி தானே நினைச்சு பயப்படாம இருக்க முடியுமா? அதுல வந்து ரெட் சிப் மியூட்டேஷன்ஸ் நடந்துகிட்டே இருக்கு. இட் கேன் எனி டைம் கேன் பிரிங் எ தீபாவளி டு அஸ். எப்ப வேணா வரலாம். அண்ட் அனதர் ஒரு ப்ராசஸ் இருக்கு. இப்ப சார் கூட ஒருத்தவங்க வந்து இந்த ரிசார்டன்ட் வைரஸஸ் பத்தி மெசேஜ்ல கேட்டிருந்தாங்க. ரிசார்டன்ட் வைரஸஸ் ஆர் ஆல்வேஸ் அ மெனாஸ். இதை எப்படி சொல்லலாம்னு பாத்தீங்கன்னா, நமக்கு வந்து கீ ஸ்வீட் பிடிக்கும். ரெண்டு பேரும் நம்ம ஒய்ஃப் ரெண்டு பேரும் ஸ்வீட் கடைக்கு போகும்போது எனக்கு கீ ஸ்வீட் பிடிக்கும், ஒய்ஃபுக்கு வந்து பக்லாவா பிடிக்குதுன்னு வச்சுக்கோங்க. நம்ம என்ன பண்ணுவோம், ரெண்டையும் சேர்த்து ரீஅசார்ட்மெண்ட் பண்ணி இதுல ஒரு 1/4 கிலோ அதுல ஒரு 1/4 கிலோ போட்டுருவோம் இல்லையா? அதே மாதிரி ஒரு பேஷண்ட்டுக்கு ஒரே நேரத்துல இப்ப நம்ம சீசனல் இன்ஃபுளுன்சா லைக் H1N1 H3N2 வருது. இவர் போய் ஒரு பேர்டை வந்து ஒரு பறவை ஆர்வலரா இருக்காரு, பிடிச்சி ஒரு இறந்த பேர்டை தூக்கி அவருக்கு H5N1 வந்துருது அப்படின்னா, இஃப் both these viruses co-infect a particular person, it can cause a novel hybrid variant. அந்த குறிப்பிட்ட வேரியன்ட் என்னவா இருக்கும் அப்படின்னா, நம்ம அம்பி தான் வந்து சீசனல் ஃப்ளூன்னு வச்சுக்கோங்க. H5N1 வந்து இப்போதைக்கு அது ரெமோ மாதிரி தான் நம்ம நினைச்சிட்டு இருக்கோம். பட் இது ரெண்டும் ஒரே நேரத்துல ஒரு ஆளுக்கு இன்ஃபெக்ஷன் ஆகும்போது இட் கேன் காஸ் அ அன்னியன் டு அவுட் பிரேக். அன்னியனா ஒரு நாவல் ஹைபிரிட் வித் ஹை டிரான்ஸ்மிசிபிலிட்டி வித் ஹை மார்டாலிட்டி. அப்படி ஒரு வேரியன்ட் பரவுச்சு அப்படின்னா நம்ம அதை வந்து எப்படி டேக்கிள் பண்ண போறோம்? ஸோ we are ready. எப்படின்னு பாத்தீங்கன்னா, we are tracking the virus. அதுக்கு என்னன்னா GISAID குளோபல் இனிஷியேட்டிவ் ஆன் ஷேரிங் ஆல் இன்ஃபுளுன்சா டேட்டா வந்து இப்ப இருக்கு. WHO இருந்து USA வெளியேறினது இது எப்படி இம்பாக்ட் ஆகுங்கிறது தெரியல, அது ஃபியூச்சர்ல தான் தெரியும். பட் எபிஃப்ளூ ஃப்ரீக்வன்சி அது என்ன பண்றாங்கன்னா, வாட் ஆர் த பெர்சன்டேஜ் ஆஃப் சீக்வன்சஸ் வித் மியூட்டேஷன், அதுவும் குறிப்பா நான் சொன்ன அந்த 3 மியூட்டேஷனோட வர்ற அந்த வைரஸுகளை அவங்க பார்த்துக்கிட்டே இருக்காங்க. தென் ஃப்ளூமெட், ஃப்ளூ சர்வர், இதை வச்சு இமீடியட் ஃபிளாகிங் ஆஃப் மெமலின் அடாப்டேஷன் மார்க்கர், அந்த இன்ஜின் மியூட்டேஷன்ஸ் நடக்கிறத உடனடியா வந்து பண்ணி அந்த இதில் கல்லிங் ஆஃப் பேர்ட்ஸ் நடந்துகிட்டே இருக்கு. தென் ஆன்டிஜெனிக் மேப்பிங் என்ன பாத்தீங்கன்னா, இப்ப நம்ம வந்து பாத்தீங்கன்னா ஒரு வைரஸ் வேக்சின் ரெடி பண்ணி வச்சிருந்தோம் அப்படின்னா, அந்த வைரஸ் வந்து ட்ரிஃப்ட் ஆகி ஷிஃப்ட் ஆகி அது அந்த வேக்சின் சீடை விட ரொம்ப தூரமா போயிட்டே இருக்கு. ஸோ வாட் இஸ் த வேக்சின் ரெடினஸ், அதுக்கும் நடந்துட்டு இருக்கு. தென் பிலோஜெனிக் ட்ரீஸ், ஹவு வைரஸ் இஸ் கெட்டிங் ரீஅசார்டட், ஷிஃப்ட் ஆகி ட்ரிஃப்ட் ஆகி போயிட்டு இருக்கு, பல்வேறு கிளாடா உருவாகுது அப்படிங்கிறதையும் தொடர்ந்து ரியல் டைம் ட்ராக் பண்ணிக்கிட்டே தான் இருக்கும். ஸோ வி ஆர் ரெடி டு டேக்கிள் எனி பேண்டமிக் இன் ஃபியூச்சர் with regards to H5N1.
Thank you.
Sir. Nice,
Thank you,
sir.
Dr.
Slide presentation, நல்ல சூப்பர் அண்டர்ஸ்டாண்டிங்கா இருந்தது சார்.
கார்த்தி
Yes, sir.
பயங்கரமா சினிமேட்டிக்கா பண்ணிட்டாரு அப்துல்.
கண்டிப்பா ஈஸியா புரியுது, டக்குன்னு புரியுற மாதிரி சொல்லிட்டாரு.
ஆமா Abdul, I like to add a small point to the doctors because nearly around 300 doctors are there. Mostly all these mutations happen only when the virus enters inside our body. For doctors, I'm going to tell you a simple technique that is practice that you can practice, whether it is COVID or season flu or bird flu, or simple technique that is called hands off face technique. Hands off face. இந்த கையை வந்து இன்னொரு 3 மாசத்துக்கு நம்ம பேஷண்ட்டை தொட்டுட்டு ஸ்டெத்தை தொட்டுட்டு வார்டுக்கு ரவுண்ட்ஸ் போயிட்டு இந்த கையை கழுத்துக்கு மேலே கொண்டு போகாமல் இருந்தாவே யூ வில் நாட் கெட் எனி இன்ஃப்ளூயன்ஸா, எனி ரெஸ்பிரேட்டரி வைரஸ், எனி ILI. தட்ஸ் கால் ஹேண்ட்ஸ் ஆஃப் ஃபேஸ் டெக்னிக். இந்த கையில் வந்து 1 ஸ்கொயர் சென்டிமீட்டரில் வந்து மோர் தென் 1 lakh வைரஸஸ் இருக்கும். ஸோ ஒன்று பிட்வீன் 2 பேஷண்ட்ஸ் ஹேண்டை சானிடைஸ் பண்ணிடணும். பாசிபிள் அப்படின்னா சோப் அண்ட் வாட்டர் வச்சு வாஷ் பண்ணணும். ப்ராக்டிகலி நாட் பாசிபிள். நம்ம ஹேண்ட் சானிடைஸ் பண்ணிக்கணும். இந்த கையை வந்து ஃபேஸ் கிட்ட கொண்டு போகவே கூடாது. பர்டிகுலர்லி when there is a respiratory outbreak, any outbreak, மாஸ்க் வேர் பண்ணிக்கணும். இந்த 3 டெக்னிக் பண்ணோம்னா 99.99% of the time doctors we can protect ourselves. So this is called hands off face technique. So this is a simple technique that can be practiced by all practitioners. Next.
ஆமா சார், தேங்க்யூ சார். நேமியா சார், உங்களுக்கு நீங்க சொல்லுங்க சார். இன் ரூரல் இந்தியன் ஹவுஸ்ஹோல்ட்ஸ், children are often responsible for feeding the backyard poultry or playing in areas where birds roam freely. Why does this social behavioral factor significantly increase the risk of H5N1 spillover in the pediatric age group compared to the adults?
I already told it many times, because children are at high risk because they don't know the fear, they don't know hygiene, they don't know anything. These hands off face technique, everything. whatever is possible, they will try to attract these organisms because of their creative nature. They play with the dogs, they cuddle them, they get rabies, they touch these wild animals, get zoonotic diseases. On an average, if you look at the world, there are for every 4 minutes, there is one zoonotic outbreak in the world. But fortunately, 99.999% of them, they stop at the single index patient. They don't spread. So if this happens, we will be getting zoonotic pandemics every now and then. Fortunately, once in 10 years or once in 15 years, 20 years, we get pandemic like COVID. So these children are the main culprits because they go out, they play, they touch these animals, feed these animals, come back, they don't wash their hands, they take it to their eye or the nose or the mouth where these viruses enter. And as I already told you, the viremia is more, the shedding is more, the viral clearance is less, they are prone for cytokine storm. All these things makes disease presence and the mortality morbidity high. So it goes without saying, pediatric population is high risk for all viral illnesses.
Sir,
Okay,
Nemi
sir.
sir,
Thank
can
you.
you hear me, sir? I want to ask a question.
Yeah, please.
Dr. Devdutt Thomas.
Yeah.
We have most of the times during our in our residential backyard, we see a lot of peacocks roaming around everywhere, sir. In most
Yes,
of
sir.
the places.
Yes,
Do
sir.
these peacocks have you any time encountered that? Is there any possibility of these peacocks harboring or transmitting the infections of
Yeah,
birds?
yeah. So actually, though the textbook don't mention, there is high possibility that any animal, any bird can harbor these viruses. And unfortunately, many of these birds, they do not die. They act as a carrier. They do have these viruses in their body. They keep on excreting as already told by Kulandeswamy sir. Lifetime they'll be excretors. They'll not be having the disease. They'll be acting as a carrier. So any bird, you have to be very cautious, whether it is peacock or peahen or whatever it is. Any bird, you have to be cautious.
And nowadays we
Kulandeswamy
have
sir, recently. Yes, sir. Please go ahead, sir.
Yeah, no, we have a lot of patients with a lot of continuous cough and expectoration and low-grade fevers going on.
Yeah.
And after we now really come to a conclusion whether that is even beyond 3 weeks, 4 weeks, the cough is persistent and
Yeah.
the thick phlegm coming out, and then we still think whether it's a viral infection, which is a low-grade viral infection going on.
Yeah.
CBC counts are all within normal range.
Yeah.
Should we really treat them with any anti-flu medications, or should we just wait and watch for it to subside by itself, sir?
So in flu, there is a rule called rule of 2. The incubation period is 2 hours. The fever is for 2 days. And the cough is for 2 weeks to 2 months. And the asthenia, body pain, severe flu lasts for 2 months. So 2 hours, 2 days, 2 weeks, 2 months. So the cough will last for weeks and months.
Sir.
So do not treat the cough. Just give a simple cough remedy that is called honey. In 5 ml of warm water, add 5 ml of honey, mix it with warm water and then give thrice a day. This cough will settle down. Usually in flu, the last doctor gets the credit. நீங்க வந்து லக்கியா இருந்தீங்கன்னா உங்களை 4வது டாக்டரா பார்த்தாங்கன்னா நீங்க தொட்டைங்க நல்லாச்சுன்னு கைராசி டாக்டர்னு சொல்லிடுவாங்க. So be the last doctor to treat the child.
Thank you, sir. Thank you so much.
Thank you, sir. Kulandeswamy sir, recent 2025-2026 reports from Tamil Nadu and Delhi have highlighted mass deaths in crows and captive zoo animals. What is the epidemiological significance of non-poultry mortality in the Indian context, sir?
These are all very dangerous indicators. That is, it clearly indicates. So the birds which are rarely affected are also now getting affected means. So there is a possibility of intensive transmission going on between various types of. Usually the birds, the wild birds are only affected. Now many birds are being affected. The crows, usually the crows resist any kind of chemical or biological the adverse situation. The crows have the remarkable ability to manage all kinds of adverse situation, but the crows themselves being affected by bird flu itself is an indication. And again, the captive animals. So recently in South Vietnam, I think around 40, more than 40 tigers, the zoo animals have died. So that means usually it is the pigs. Now it is being, the zoo has access to only the zoo, the birds are, they prevent the access for the wild birds. But in the zoo, the animals are not being protected with the net. So the animals like the lion, tiger are likely to have infected from the wild birds. So the mortality also is very high. So it is again, it is a dangerous. It may spread to the zoo visitors. That is one aspect. And now many endangered species are protected in captive sanctuaries. So now these endangered species, once infected with this kind of the highly pathogenic bird flu, so these species themselves may be wiped out. We have to be, so these are all very warning signals. We have to be careful about these warning signals. It indicates that this virus is, as Dr. Farooq is telling, the mutation, it is slowly, it is breaking the species barrier, and unusually it is spreading to other mammals and other things. So it can also spread to cattle, the farm animals. So once it comes to farm animals also, from birds, pigs, farm animals, then the humans, then direct to direct human transmission. Originally, the swine flu came from almost about 9 decades back in Mexico. The swine flu jumped from pigs to humans. Now, invariably, the transmission is between human to human. So there is every possibility that if we don't act properly scientifically in an One Health approach, so there is every possibility that it may, like the swine flu, this bird flu may become a human to human as the main source of infection and transmission. So we must be alert, and One Health approach is the best way to tackle this situation.
Okay, so this partly answers Dr. Devdas sir's question also. Farooq sir, as per our knowledge, currently in India, we don't have available vaccines against H5N1. Is there a vaccine in pipeline?
Regarding vaccines, we have 2 already approved vaccine in USA. It is cleared by FDA for emergency use. Ordance and Aripandrix. Both of them are cell-based inactivated vaccines. Inactivated vaccine technology is our conventional approach with adjuvant-based technique, because H5 in H5N1 virus is not is a very less immunogenic. So we add adjuvant to create more immunogenicity, and it is approved for more than 6 months old. And in India, NIV, National Institute of Virology, and Serum Institute of India has collaborated to produce a reassortant baculovirus. Baculovirus is a virus infecting insects. Other base panni, they are creating a vaccine for H5N1 for South Asia. Then Moderna, again creating an mRNA 1018 vaccine. Then Arcturus GSK is creating a self-amplifying mRNA vaccine. NIAID is creating a nanoparticle dependent vaccine. So already 2 vaccines are available for at America for use in poultry workers, culling team, already irukku, but it is an emergency use purpose, not for a population based purpose. India 2026 end we will be getting our indigenous vaccine based on baculovirus. இதுல என்ன ஒரு விஷயம் அப்படின்னு பாத்தீங்கன்னா, கொரோனா வைரஸுக்கு வேக்சினை 1.5 வருஷம் கழிச்சு கண்டுபிடிக்கும் போதே ஆன்டி வேக்சர்ஸ் என்ன சொன்னாங்கன்னா, இவங்க வேக்சினை கண்டுபிடிச்சிட்டு பேண்டமிக்கை பரப்புறாங்க அப்படின்னு சொன்னாங்க. இங்க பாத்தீங்கன்னா நம்ம பேண்டமிக்கு ப்ரிப்பேர் ஆகுறதுக்கே ஆல்ரெடி வேக்சின்ஸ் கிரியேட் ஆயிருக்கு. இதுக்கு தான் என்ன சொல்ல போறாங்கன்னு தெரியல. we should be ready to tackle this type of things. Thank you.
Thank you, sir. Neminathan sir.
So public
yes.
We have to tell them that every 1 second 1 crore children are getting these vaccines. On the point நம்ம சொல்லணும். So far the most important best invention so far next to ORS is called the vaccines. It's a lifesaver அப்படிங்கறத சொன்னோம். Every 1 second 1 crore children are getting these vaccines. So side effects are extremely rare ங்கறதை நம்ம insist பண்ணிட்டே இருக்கணும். Because we have to go one step before the anti-vaccine people tell them.
Yes, sir. Thanks, sir. Kulandasamy, sir. Despite frequent poultry outbreaks, human H5N1 cases in India remain extremely rare, with only one notable case reported in 2021. Is this due to low viral infectivity, or are there any epidemiological surveillance gaps that might be masking the true situation?
Actually, the main reason is every virus or every organism, bacteria or virus or whatever it may be, it has its own preference to affect the people. So the lower the mortality, the higher the probability for the organisms to multiply and getting transmitted. So the mortality is about 50% among the human beings. The mortality is again up to 75% in highly pathogenic avian influenza viruses. So the virus may be looking for shifting to the low mortality animals and other. So that is what the virus is looking for its own survival. Although it is a very, very minute particle, it also has a lot of intelligence, like the dengue virus or the Aedes mosquitoes. So currently, it is the species preference or the specificity, but it is slowly getting it is slowly jumped by the virus. So we have to institute proper surveillance among animals, among birds, among the human beings for all the potentially pandemic and epidemic prone diseases, like what I was explaining for the plague. Still it is going on the same way. So a lot of things have been done, are being done by in the animal husbandry high security laboratory in Bhopal, but still it is well known only to the people involved. So I think so all the practicing veterinary people, all the practicing the human doctors, the people, still we need to be oriented and educated more on taking samples and where these samples are tested, how these samples are have to be sent. So we need to develop more on surveillance so that we can monitor. So COVID, we are able to monitor at the state level in Bangalore, in Hyderabad, and in Chennai. We were monitoring even the Directorate of Public Health Office, the lab we established has the capacity to monitor the mutation among the COVID-19. The same way, so the regional virological departments in our government medical colleges and the state virology lab have to be equipped to monitor these kind of cases.
Thank you, sir.
Okay, sir.
On the lighter side, Karthikeyan, sir was telling about the intelligence. So when you look at the intelligence, the humans are supposed to be the most intelligent among the animals, and followed by chimpanzee. Interestingly, crow ranks the third most intelligent. Human, chimpanzee, crow. Crow is intelligent. And another important thing is, when you look at the intelligence to the size of the organism, these unicellular organisms, bacteria and viruses, are supposed to be multiple times intelligent than human beings. Bacteria and viruses are most intelligent among the living organisms.
Yes, sir. That's true. Farooq sir, you have already told, but once again, we want to get the answer from you. After what you have told about the forthcoming pandemic, we are in real panic. So once the vaccines are ready and in our hands, can we all get that before a possible pandemic outbreak?
Vaccines work by mechanism of immunological priming. We may see it as a good option to give vaccine even prior to pandemic starts, but it may not work with influenza because influenza virus change day by day. With changing virus, we need vaccines to be changed and updated. இப்போ நம்ம ஒரு வேக்சின் இன்னைக்கு கொடுத்துடலாம். பட் நமக்கு பேண்டமிக் வரும்பொழுது பாத்தீங்கன்னா அந்த ஆன்டிஜெனிக் ஷிஃப்ட் ட்ரிஃப்ட் ஆகி அந்த ரீஅசர்மெண்ட் ஆகி அது ஒரு புது வைரஸா மாறி இருக்கும். பட் அவ்வளோ இம்யூனிட்டியை கொடுக்குமாங்கிறதே நமக்கு டவுட். ஸோ வி மே நாட் கிவ் இட் அஸ் அ பாப்புலேஷன் பேசிஸ் வேக்சின் ஸ்ட்ராட்டஜி இப்போ ஒர்க் அவுட் ஆகாது. பட் வி கேன் கிவ் ஃபார் ஸ்பெஷல் வல்னரபிள் பாப்புலேஷன்ஸ் லைக் போல்ட்ரி ஒர்க்கர்ஸ், கல்லிங் டீம், வெட்டர்னரி டாக்டர்ஸ், அப்புறம் அந்த அவுட் பிரேக் சுச்சுவேஷன்ஸ்ல மட்டும் வி மே யூஸ் தட் வேக்சின். தேங்க்யூ.
Okay, sir. Neminathan, sir.
I'd like to add to
Yes,
Farooq
sir.
Abdullah. These vaccines, they as already told, there is a minor antigenic drift that happens every year. Minor drift means slight change in the hemagglutinin or neuraminidase. Sometimes once in a couple of years, 15 years, 20 years, 30 years, there will be a major change that's called shift. If the shift occurs, then there will be a pandemic. Influenza pandemic, Russian pandemic, swine flu pandemic, and along this shift can occur once in a couple of years, a decade or 2 decades. Drift வந்து ஆயிட்டே இருக்கும். ஃபார் எக்ஸாம்பிள் இப்போ வந்து நம்ம வேக்சின் வந்து H1N1, H3N2 இன்ஃப்ளூயன்ஸா பிக்கு வந்து ட்ரைவலன்ட் வேக்சின் இருக்கு. இந்த வேக்சின் வந்து WHO வந்து மேனுஃபேக்சர் பண்ண சொன்னதுக்கு அப்புறம் there was a small drift that happened that is called subclad K. அந்த சப்கிளாட் கேங்கிறது தான் இப்போ நிறைய இருக்கு, இந்தியாவில் வேர்ல்டு ஃபுல்லாக இருக்குது. பட் அன்ஃபார்ச்சுனேட்லி இட் இஸ் நாட் ரெப்ரசன்டட் இந்த வேக்சின் மேனுஃபேக்சரிங் ஸ்டார்ட் ஆன பிறகு இந்த சப்கிளாட் கேங்கிறது வந்திருக்கு. பட் ஃபார்ச்சுனேட்லி the vaccine presently available gives cross protection to subclad K. So they keep on changing the நம்ம ஹீரோஸ்லாம் சட்டையை மாற்றி போட்டு ஒரு கணத்தில் ஒரு மச்சம் வச்சுக்கிற மாதிரி மாற்றிட்டே இருப்பாங்க. டபுள் ஆக்ஷன், ட்ரிபிள் ஆக்ஷன் மாதிரி பண்ணிட்டே இருப்பாங்க. That's called minor antigenic drift. Major is called shift. Yeah.
Okay, sir. Neminathan, sir, another thing also we would like to get from you, that is, how does the high prevalence of iron deficiency anemia and vitamin A deficiency in Indian children affect the outcome of this H5N1 infection?
Yeah. For any illness, whether it's viral or bacterial or any illness, you need to have a good innate immunity and adaptive immunity. In a child with severe acute malnutrition, the adaptive immunity is low, whereas children with vitamin D and vitamin A, vitamin D now is considered as a hormone. So your human immunity is low. The protective IgA, secretory IgA level is low. So all these respiratory illnesses, influenza, para-influenza, adeno, respiratory, rhino, all these viruses, the incidence, mortality, morbidity is high whenever it's low. So what we say is when you get a child with measles, immediately you give vitamin A, vitamin D. Also, we ask them to give zinc. So that's the reason even viral diarrheas, we give all these drugs. So these malnutrition, vitamin A deficiency, vitamin D increase the morbidity and mortality, not only in children, even in adults.
Okay, sir. Sir, Kulandasamy, sir, you told about live bird markets in Southeast Asian countries, even in India. What role do these markets play in the spillover of H5N1 between the species? Already you have answered, but we want to again re-insist on this point, sir.
Yes, the same thing happened in the COVID. Actually, in China, so they have this habit of eating the lizards and other the chameleons and the snake all came. So there was a famine. So there was a huge famine in the east coast region of China. So following that, the Chinese people started eating whatever they are able to get in, because these little creatures, the snakes, these frogs and other creatures have a tremendous ability to survive any kind of situation. So they are the only food available. So that is the practice still continues. Now it has become a staple food among many parts of China. So the Chinese wet market in Wuhan. So that is one theory, and another theory is the research, the deliberate research with the virus in a laboratory in Wuhan. These are two theories. One theory is the wet market theory. So in the wet market, what happens? All kinds of the creatures are being brought for sale. So it spreads from one bird or one animal to another. So then the same way, because of the poor hygiene and improper handling of these birds, and again another one a very dangerous practice is the sick birds. The sick birds may also be brought for sale. So then the sick birds may be excreting the virus through the oral route and the fecal route. So then it spills over to pigs and the other sheep and other products. So this is the situation. So it is a very dangerous. So we need to improve our wet markets. The wet markets are important, and we can take some periodic samples in wet markets also to monitor the situation.
Okay, sir. Thank you, sir. Farooq, sir, you have already told about the vaccine and also about drift and all. So, will our annual shot against the seasonal flu give protection against this H5N1 also?
Maybe sir already சொல்லிட்டாங்க annual flu shot வந்து it won't provide immunity against H5N1 which is a novel virus. நம்ம ஏற்கனவே பாத்தீங்கன்னா ஃப்ளூஆரிக்ஸ் டெட்ரா அப்படின்னு சொல்லிட்டு போயிட்டு இருந்திருப்போம். இப்போ லாஸ்ட் 2 இயர்ஸா வந்து அது ட்ரைவேலண்ட் வேக்சினா மாறி இருக்கு. It has only virus H1N1 pandemic 2009 virus, H3N2 virus and influenza B Victoria strain virus. அது 3 தான் இருக்கு. H5N1 அதுல இல்ல. So it won't provide any immunity against H5N1. ஆனா இன்னொரு அடிஷனல் பெனிஃபிட் ஒன்று இருக்கு. என்னன்னு பாத்தீங்கன்னா நம்ம ஏற்கனவே பார்த்தோம் இல்லையா இந்த எம்பி இருக்குல்ல சீசனல் ஃப்ளூ அது வரவிடாம நம்ம பார்த்துக்கிட்டோம் அப்படின்னா we can prevent this reassortant hybrid viruses வர்றதை வந்து we can avoid, we can diminish the chance. அதை அவாய்ட் பண்றதை விட we can diminish the chance. அதனால இன்ஃப்ளூயன்சா வேக்சின் will give protection against seasonal flu and also it will diminish the chance of novel hybrid variants அது arise ஆகிறதுல இருந்து it will protect. Thank you.
Okay, yeah, sir. So I request all the doctors who are attending the CME to take influenza vaccine annually. So if you can take yourself, if you protect yourself, that's very, very important, because we as doctors, particularly physicians, pediatricians who are sitting inside the closed chamber wherein we are exposed constantly to viruses. One virus that can affect our own health is influenza virus. Irrespective of age, you please take influenza vaccine annually.
Okay, sir. Sir, Kolandasamy sir, what are the disinfectants against, active against this avian influenza virus? Can you explain more about the effective concentration and recommended use of this disinfectant, sir?
Okay, that's a very, very, very important question. And before that, to add on to Dr. Neminathan's point, the doctors, we should take the vaccine, influenza vaccine. That is a very important point. At the same time, if we don't sleep properly, if we don't sleep at least 8 to 9 hours a day, then our immunity will drastically go down. So whether we get vaccinated or we have good nutritious food, so the lack of sleep makes us more vulnerable to all kinds of infections, particularly the influenza viruses. Coming to the very valid question of important question of the disinfectants, I think the surgical spirit, it is very effective. We can use for hand wash. Even the 1% the Dettol we normally which is being sold in the market is very effective against the H5N1 viruses. And usually for floor, the two items which we are using normal situations or during the COVID also, it is very useful. This Lysol, which contains phenol and the soap, that is advantage with the Lysol. See, the other disinfectant does not contain.
They want to protect. Avian Flu-the CME. Influenza vaccine trivalent H1N1, H3N2 and Victoria virus influenza type 3க்கு தான் இப்ப tetravalent னு வந்திருக்கு. பட் அதுவும்
Madam, yeah, there was a question from doctors about this influenza vaccine. Previously, we had tetravalent vaccine, which had a Yamagata strain. This strain is removed from the tetravalent. Now it is made as trivalent because after COVID, Yamagata strain has disappeared from the globe. So that has reduced the cost of influenza vaccine to nearly 1,000 rupees. It has come down. So the present vaccine available, recommended by WHO, is trivalent vaccine. in which does not contain Yamagata strain. So this trivalent vaccine does not give protection against H5N1. That's very, very important. But as rightly told by Dr. Farooq, it will give protection against the secondary mortality benefits are very high. So it will give protection against your seasonal influenza that is a slow and a constant killer, particularly in vulnerable population, young children and adults and also high-risk populations. So you have to give this flu vaccine. Sorry, sir. Sorry to interrupt. There was a question in between.
Karthikeyan, sir. Kavandeswamy, sir, just a minute, sir. So, benefit of also being an IMA member, the IMA headquarters gives a concessional rate flu quadri vaccine to all its members for 5 members per member, 5 vaccines per member at the rate of 930 rupees. It will be circulated through the branches. All of you can utilize this opportunity at a concession rate.
Thank you, sir.
Thank you for the
Very,
information,
very
sir.
important message.
Yes, sir, definitely. And this is for Dr. Farooq, sir. Can we dream about a universal vaccine against all these circulating influenza viruses, H1N1, H3N2, and in future H5N1? Dr. Vinay, can you please mute yourself, please? Dr. Vinay.
Dr. Vinay, sir,
Please mute yourself.
அதாவது இந்த இன்ஃப்ளூயன்சா வைரஸஸ்ல பொறுத்த வரைக்கும் என்ன தலைவலினா அது மாறிட்டே இருக்கு. ஆன்டிஜெனிக் ட்ரிஃப்ட் ஆகுது, அதுக்கப்புறம் ஒரு டிகேட்ஸ்ல ஷிஃப்ட் ஆகுது, ரீஅசர்ட்மெண்ட் ஆகுது. வேக்சின்ஸ் வந்து திருப்பி நம்ம ரெடி பண்ணா கூட வருஷம் ஒரு தடவை சார் சொன்னாங்க வேக்சின் ப்ரொடக்ஷன் பண்ணிட்டு பார்த்தா அது ஒரு ட்ரிஃப்ட் ஆயிருக்கு. இந்த மாதிரி பிரச்சனை இருக்கு. யுனிவர்சல் வேக்சின் அது எப்படி அப்படின்னு பார்த்தா இந்த 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 காமெடி எல்லாரும் பார்த்திருப்பீங்க இல்லையா? கோவில் படத்துல இருக்கும். பழனி படிக்கட்டு மாதிரி உடம்பு இருக்கு, தலையை கொண்டு போய் இது வடிவேல் ஃபிட் பண்ணி வச்சிருப்பாரு. ஸோ யூனிவர்சல் வேக்சின் ஒர்க்ஸ் இன் தட் பிரின்சிபல் ஒன்லி. இந்த 23ஆம் புலிகேஸ்லயே அப்படிதான். இந்த தலை வந்து அங்க அந்த முண்டத்துடன் சேர போகிறதுன்னு சொல்லுவார் இல்லையா? அது மாதிரி இன்ஸ்டெட் ஆஃப் டார்கெட்டிங் த ஹெட் வித் சோ மெனி டிஃபரன்சஸ், அந்த நியூரோமினிடேஸ் இருக்கு இல்லையா, ஹைலரண்டேஸோடைய அந்த ஹெட்ல தான் பாத்தீங்கன்னா மோர் அமௌண்ட் ஆஃப் டிஃபரன்சஸ், டெய்லி சேஞ்சஸ் நடந்துகிட்டே இருக்கு. மனுஷனோட மூளை தான் டெய்லி மாறிக்கிட்டே இருக்கு, ஆனா உடம்பு பார்த்தா அப்படியே தானே இருக்கு. டார்கெட்டிங் ஸ்டாக் விச் இஸ் ஹோமோஜினஸ் மேக்ஸ் த டிஃபரன்ஸ். அதை யார் பண்றான்னு பாத்தீங்கன்னா அந்த மாடர்னா பண்றாங்க. mRNA 1018 vaccine வந்து it is in phase 3 trial now. It is a multi-antigenic vaccine. Instead of targeting the head of HA protein, it targets the stalk of HA. இந்த போட்டோல கூட இருக்கும். Head of the HA வந்து it is morely differing, but conserved region is targeting the stalk. So head mutates daily while stalk remains dumb forever without changes. அதனால நம்ம இந்த ஒரு வேக்சினை ரெடி பண்ணிட்டோம் அப்படின்னா இது வந்து வைட் ரேஞ்ச் ஆஃப் வேரியன்ட்ஸை கவர் பண்ணும் அப்படிங்கிறது நம்மளுடைய நம்பிக்கை. தேங்க்யூ.
ஓகே சார்.
நம்ம இப்ப மீட்டிங் போட்டு டிஸ்கஸ் பண்ணிட்டு இருக்கும்போது வைரஸும் மீட்டிங் போட்டுட்டு இருக்கோங்க சார். By the time mRNA vaccine comes in, it will form another subclad. It will be totally mRNA vaccine resistant வந்துரும் சார். So they are all more intelligent than us.
Yes, sir. So, Neminadan sir, நீங்க already இந்த prophylaxis பத்தி சொல்லிட்டீங்க. But if a hotspot of H5N1 is identified in a rural village, what are the current Indian National Center for Disease Control recommendation for this post-exposure prophylaxis in children who attended the school with a confirmed case for the children?
Yeah, if there is a confirmed case that is happening inside a school where the child has been confirmed by RT-PCR H5N1, all the contacts, including the teacher, housekeeping, everybody, including the children, they have to be given the double the dose are recommended Oseltamivir. For example, children more than 40 kilos, 150 milligram OD for a period of 14 days because they excrete longer, the clearance is longer. So all contacts should be given a higher dose for a longer duration. For children, it's for 14 days. So you have to give them. So not only like this, for this virus, for example, hand, foot, mouth disease, நம்ம ஊர்ல நிறைய பார்க்கிறோம். நம்ம ஊர்ல இருக்கிறது luckily does not cause fatality, mortality, myocarditis வரதில்லை. Whereas in China, USA எல்லாம் mortality அதிகமா இருக்கு hand, foot, mouth disease. ஒரு குழந்தைக்கு hand, foot, mouth disease இருந்துச்சுன்னா சைனால உடனே ஹோல் ஸ்கூலை க்ளோஸ் பண்ணிடுவாங்க. ஹோல் ஸ்கூலை வந்து ஸ்கிரீன் பண்ணி இது பண்ணுவாங்க. எல்லா சில்ட்ரனையும் ஸ்கூலவே க்ளோஸ் பண்ணிடுவாங்க. மார்டாலிட்டி இஸ் வெரி ஹை பிகாஸ் ஆஃப் மயோகார்டைட்டிஸ். So children are at high risk because of going to school. So you have to be very, very cautious. Any suspected contact, you need to treat all the contacts with the post-exposure prophylaxis.
ஓகே சார், தேங்க்யூ சார். குழந்தைசாமி சார், உங்களோட எக்ஸ்பீரியன்ஸ்லேருந்து நாங்கள் நிறைய பாயிண்ட்ஸ் தெரிஞ்சுக்கிட்டோம். இன்னொரு பாயிண்ட் நாங்கள் தெரிஞ்சுக்கணும்னு ஆசைப்படுறோம். ஹாஸ்பிட்டல்ஸ் ஆர் கால்ட் ஆம்பிளிஃபையர்ஸ் ஆஃப் இன்ஃப்ளூயன்ஸா அண்ட் டெங்கு. ஸோ வாட் ப்ரிகாஷன்ஸ் ஹாஸ்பிட்டல்ஸ் ஹேவ் டு டேக், சார்?
Important. So the swine flu experience, so we have noticed that only the cities where there are large hospitals are there. So the infections are pooled, and from the hospitals it gets amplified and spreads to different parts of the. Similarly, the same thing happened in COVID-19 also. So that is why, so every hospital, so there must be some infection control procedures should be set in motion. Every hospital should have the hand wash. The hand wash while entering into the hospital, they have to wash the hands. Anybody who is not washing their hands, who is coming from outside, should not be allowed to enter into the hospital. So slowly we have to bring in this practice. And similarly, anybody leaving the hospital, this is what we call it as a reverse hand wash. They should wash their hands and leave the hospital premises. This is very important. And again, and another thing, the disinfectants we were talking in the previous question. There are several disinfectants are there, but let us standardize and remember it. One is the surgical spirit that we use it for the hand sanitizer. That is very important. And another thing is for floor, we can use the Lysol as an advantage. The Lysol as soap as well, it contains the cresol. So it is highly effective in removing the dirt. Once the dirts are removed, then the effectiveness of cresol increases manifold. We can use 5% Lysol in labor ward, in ICU, the other places. So we can use 2% Lysol in different places. And the hospital changeover chapel practice. So street chapels should not be allowed into the hospital premises at the entrance, like temple. So this practice is followed in many countries like Singapore, Japan, Sweden. So nobody can enter the hospital, including the doctor, the patient, or the visitor, without changing over to the hospital. So the hospital chapel, every day they are being disinfected, and the next day they are put back in a fresh for use by the new visitors or patients or doctors or staff. That is very important. And then ventilation. So all these hospital procedures we have to follow. Infection control procedures we have to, and then use of face mask. Now, not only this influenza-like illness, the drug-resistant tuberculosis makes the doctors and other hospital staff more vulnerable. That is a potential threat. The healthcare people we are facing. So we have to put in a robust infection control measures in all hospitals. That is very important. Otherwise, these hospitals will act as an amplifiers of the diseases, particularly the influenza-like illnesses. And in case of dengue, the dengue virus starts, the outbreak starts in a very few places. Because of the transovarial transmission, the virus lies dormant in the eggs of the Aedes. The Aedes eggs in containers like tires and other unused containers, they resist desiccation for quite a long time, more than a year or more. So once the rain comes, so these containers are getting filled, and the infection. The Aedes mosquitoes, so the new Aedes mosquitoes are born with the virus because of transovarian transmission. And once these children or these patient dengue fever case, they come to a government hospital or a private hospital or even a small primary health center or clinic, they are very infective. So if Aedes mosquitoes are present inside the premises of hospital, then it will spread to other people. It will spread to other areas. There is one particular area in a major city. I don't want to name the institution. That's not the idea. So 2 examples I will give. We were surprised to know that all the 4 types of dengue viruses were present in that particular street. Then subsequently we were able to identify that particular hospital, people come from across the country to get treatment for even for dengue fever. So then, so if you want to take the subtype of the dengue virus, we can easily collect from that particular street all the 4 types of the dengue viruses. Similarly, in an hospital, when we made a call, so I think your result has come as a dengue positive. Then are you available at home? Are there any cases in your area? So immediately that man was answering, sir, for an orthopedic condition, for my fracture, multiple fractures, I am admitted in the hospital for the past 1.5 months. A person who is admitted in the hospital for the past 1.5 months tested positive for dengue. So the hospital should be kept meticulously clean so that it is free from not only the hospital and the adjoining streets, so that these Aedes mosquitoes are not infested the hospitals and they transmit the dengue to hospital staff, other patients, visitors, and the neighboring adjoining streets. So this is how the role of keeping the hospitals meticulously clean, meticulously free from the vectors like Aedes mosquitoes is very, very important. So that is the reason the hospital, the most of the influenza outbreaks, if you take the history and look at, they will be emerging from major cities. If you look at the commonalities in these major cities, you can find one is it will be connecting multiple cities or multiple towns. And another, this thing, the city may be thickly populated. And more over this, all these cities will be having major hospitals. We admit all kinds of patients and give treatment. So this is the major cities. This is how the major cities act as the epicenter of pandemics like influenza-like illness. Particularly, we have seen during the swine flu outbreaks. As well during the COVID-19 outbreaks. So very important that we have to be very, very careful.
Thank you very much, sir. Adding a very, very important valid point for all the doctors who are attending this. As a hospital, we follow these NABH norms and WHO norms in controlling these infections. During outbreaks of COVID and influenza outbreaks, swine flu outbreaks, the door knobs, hand railings, the viruses can remain live for more than 24 hours. So what we do is every 2 hours we use our housekeeping people to sanitize the doorknobs and handrails. That's very, very important. From the doorknobs, it comes to the hand. From the hand, it goes to the eyes and nose and throat. All those people who come inside will get infected. So that's very, very important. Another important thing is we see lots of cases of dengue admitted in our hospital. For all those children who are admitted in dengue, what we do is we put them inside a net, a mosquito net. So these children will not be bitten by mosquitoes in the hospital, and these mosquitoes will not get infected from the children, because we get dengue children from throughout Tamil Nadu. So we make sure that our children do not spread it to other children by reversely protecting them by keeping those infected children under net, mosquito net. This practice can be practiced by all hospitals. This is a simple practice which can reduce the spread of Aedes from the hospital. All dengue patients should be inside the mosquito net in the hospital.
Sir, thank you, sir. Sir, one last question for Kolandasamy, sir. Is there any carrier state or from the statistics available, any gender or age prevalence or incidence of this influenza, avian influenza, sir?
There are no carrier states. The diseased birds, either they die or they survive. If they survive through the oral route and fecal route, they continue to excrete the virus for about maximum of about 10 days. Then the bird becomes free. The surviving birds are the main cause. That is why people go for the culling of the birds. They declare 3-kilometer radius as the affected area. They notify and they go for culling of the birds. And the poultry owners, the keepers, there is a provision is given. The market rate of the cost of based on the number of birds killed, they are being given the compensation, and how these birds have to be properly killed without this thing, and how the flesh of these killed birds have to be disposed. So all these guidelines are being given. Even in 2005 itself, very high level committee comprising of the secretaries of Animal Husbandry Department, Forest Department, Director General of Health Services, and Secretary to Government of India Health Services, they are all being a high level, and they have been given with the proper guidelines and delegated the powers. And similarly at the state level and at the, similarly at the district level, the One Health approach is fast taking shape in case of this avian influenza, leptospirosis, then rabies. So these kind of diseases, it is taking shape. So no carrier states in birds.
Okay, sir. Thank you, sir. And a last question for Farooq, sir. Sir, is there any specific dietary intervention you advise to boost up the immunity against H5N1?
நம்ம மக்கள் வந்து எப்பயுமே ஒரு வைரல் டிசீஸ் நம்மகிட்ட பரவுச்சுன்னா போதும், டெங்குக்கு வந்து ட்ரீட்மெண்ட் இல்லை அப்படின்னு சொன்னா போதும், உடனே அவங்க ஆல்டர்னேட் மக்கள், அப்புறம் சூடோ சயின்ஸ் மக்கள்லாம் ரொம்ப குதூகலம் ஆயிடுவாங்க. இப்ப நம்ம வந்து H5N1க்கு ட்ரீட்மெண்ட் இருக்குன்னு சொல்ல போறோம்ல, ட்ரீட்மெண்ட் இருக்கு, அதனால சந்தோஷமா ட்ரீட்மெண்ட்டை சொல்ல போறோம், வேக்சினும் இருக்கு, எல்லாம் இருக்குன்னு சொன்ன உடனே அவங்க எங்க போவாங்கன்னா ஃபுட்டுக்கு தான் போவாங்க. மோஸ்ட் ஆஃப் த சூடோ சயின்டிபிக், அப்புறம் வந்து அன்ரேஷனல் அன்சைன்டிபிக் திங்ஸை வந்து மக்கள்கிட்ட பரப்புவாங்க. பட் ஃபுட்டை பொறுத்த வரைக்கும் எவிடன்ஸ் பேஸ்டா பாத்தீங்கன்னா ஆல்வேஸ் மேக்ரோஸ்ல 3 மேக்ரோஸ்ல நம்பர் 1 ப்ரோட்டீன், வி ஆல் நோ. ஸோ வென் யூ டேக் ப்ரோட்டீன் ரிச் ஃபுட், யுவர் இம்யூனிட்டி வில் பி ஃபிட் அண்ட் இட் வில் ஃபைட் அகைன்ஸ்ட் எனி இன்ஃப்ளூயன்சா இன்ஃபெக்ஷன். ஸோ ப்ரோட்டீன் எனர்ஜி மால்நியூட்ரிஷன் இருக்கிற சில்ட்ரனுக்கு தேர் வில் பி சிக்னிஃபிகன்ட்லி இன்க்ரீஸ் ரிஸ்க் ஆஃப் மார்டாலிட்டி ஃப்ரம் இன்ஃப்ளூயன்சா. இது வந்து எல்லாரும் அக்செப்ட் பண்ணிக்கிற விஷயம். We have to reduce our calories through carbs, that to refined carbs, அதுக்கப்புறம் வந்து sugars, அது எல்லாத்தையுமே கட்டாயமா கட் ஆஃப் பண்ணணும். ஃபைபர் ரிச் ஃபுட், விட்டமின் டி லெவல் should be maintained optimally through either through supplements or through food, mainly through இந்த சூரியனை நம்ம பார்க்கறது இல்லை. சூரியன்ல நம்ம ஒரு டெய்லி ஒரு 20 நிமிஷமாவது சூரியனுக்கு நம்ம உடம்ப காட்டணும் அப்படின்னா விட்டமின் டி தானாவே கிடைச்சிடும். தென் omega-3 fatty acids function as anti-inflammatory things. அதுக்கப்புறம் குழந்தைசாமி சார் சொன்ன உடனே இந்த பாயிண்ட்ஸ் எல்லாம் ஆட் பண்ணிட்டேன். ஸ்லீப் அண்ட் மென்டல் ஹெல்த் வில் இம்யூன் பூஸ்டர்ஸ். அது பிசிக்கல் ஆக்டிவிட்டி, மெயின்டைனிங் குட் பாடி வெயிட், இதெல்லாம் நம்ம வந்து எவிடன்ஸ் பேஸ்ட். பட் இந்த இம்யூன் பூஸ்டிங் விஷயம் வந்து பாத்தீங்கன்னா அதுல இருதலை கொல்லி தான், அது டபுள் எட்ஜ்டு ஸ்வார்டு. வென் யூ பூஸ்ட் இம்யூனிட்டி அகேன்ஸ்ட் அன் அக்ரெசிவ் வைரஸ், டூ மச் ஆஃப் எனிதிங் மே ஹார்ம். ஸோ அதனால என்னன்னா நீங்க வந்து இம்யூனாலஜிக்கலா ஃபிட்டா இருக்கிறது ஓகே, பட் வென் யூ பூஸ்ட் சம்திங், இம்யூனிட்டியை பூஸ்ட் பண்ணும்போது அது வயலண்ட் வாரை வந்து ரெடி பண்ணி லங்ஸ்ல வந்து டூ மச் டேமேஜ்ல கொண்டு போய் விடுறதுக்கும் வாய்ப்பு இருக்கு. ஸோ வி ஷுட் நாட் ரிசார்ட் டு அன்சைன்டிபிக் அண்ட் சூடோ சயின்டிபிக் சொல்யூஷன்ஸ். அதே மாதிரி ஃபுட் சொல்யூஷன்ஸ், இதை குடிங்க அதை குடிங்க, அதெல்லாமே நமக்கு தேவையில்லை. ஸோ ஃபுட்டை பொறுத்த வரைக்கும் ப்ரோட்டீன் ரிச் ஃபுட், ரெடியூஸ் கார்ப்ஸ், இன்க்ரீஸ் யுவர் ஃபைபர்ஸ், have adequate vitamin D either through supplements or through sunlight exposure. omega-3 fatty acids வந்து நல்ல ஃபிஷ், அப்புறம் அது முடியலைன்னா சப்ளிமெண்ட்ஸ். கெட் குட் ஸ்லீப் அண்ட் மென்டல் ஹெல்த். நம்ம மக்களுக்கு நமக்கு கொஞ்சம் கொஞ்சமா குறைஞ்சிக்கிட்டே வருது நாளுக்கு நாள், அதை கொஞ்சம் சரி பண்ணிக்கணும். தென் பிசிக்கல் ஆக்டிவிட்டி அண்ட் மெயின்டைன் குட் பாடி வெயிட். அதுதான் சார் நம்மளோட அட்வைஸ். தேங்க்யூ சார்.
மிக்க நன்றி சார். தேங்க்யூ சார்.
தேங்க்யூ சார்.
Thank you, sir. We'll wind up with the meeting, sir. Thanks a lot to all the speakers and all the participants. Thank you once again.